Well, we know Edmondo's here, so
It should be on now.
Yeah. Well, I'll just finish this just to make sure everybody saw. If you wanted to make a public comment, here is the National Advisory Council address. Please note that these are actually just comments. They're not presentations, and they are limited to 3 minutes each.
Hey, Jamie, I'm on now, I think.
Perfect. Next slide, please, Jen. And then I'll turn it over to Edmondo. Well, no, first he's got to accept our minutes. So it's okay. I'm still turning it over to Edmondo before he turns it back to me. Edmondo, I'll turn it over for our
yeah. All right. All right. So I now have to figure out where we are on the agenda. Sorry.
Okay. So all you need to do at this point is we're accepting edits or changes to draft minutes, and then you turn it back over to me. Okay.
So I hope, thank you, Jamie, and apologies for that. I tried 4 different devices. I finally found one that would work. So I hope everyone had a chance to review the minutes. Are there any from the NAC members, any edits to the minutes as the draft minutes as sent out?
No.
All right. Is there any opposition to approval of those minutes?
No.
All right, hearing none, the minutes are approved by consensus. Jamie, it's yours.
Super. See, you thought you were going to hear a lot from me this meeting, more than usual, and you got even more. So very exciting. So please, Jen, next slide, please. So we wanted to just start off with a tribute. You know, many of you have heard about the recent loss of Dr. Sandy Schwartz, who died on June 25th. Dr. Schwartz was such an important voice in the advancement of AHRQ's mission. He served as on AHRQ's National Advisory Council from 2014 to 2017, and on the U.S. Preventative Services Task Force from 2008 to 2011. He also served on many AHRQ study sections and expert panels. Dr. Schwartz was a longtime faculty member at the University of Pennsylvania, where he served as the Leon Hess Professor of Medicine and Health Management and Economics at the Perelman School of Medicine at the Wharton School of Business, and as a senior fellow at the Leonard David Institute of Health Economics. And his award-winning research focused on assessing the incremental benefits, harms, and costs of innovative medical interventions and technologies and their applications to clinical decision-making. And me personally, and I think many of our NAC members will always remember Sandy coming to our NAC meetings armed full of fruit that he bought at Costco for our meetings, because he didn't like that we couldn't have food at a federal meeting. And we will all clearly miss his towering intellect and warm personality. Next slide, please, Jen. So this is a call to my NAC members here, but also members of the public, to let folks know that we are recruiting new NAC members every year. 7 members rotate off. And so we are challenging you all to think about members who would make good National Advisory Council candidates. People who have expertise in research, medicine, or other healthcare professions. And we're looking for representatives from the private healthcare sector, healthcare economics, information systems law, ethics, business, public policy, and patients and consumers of healthcare. It's a really easy application process. All you need to do is send a resume and a statement that you're willing to serve, addressed to myself, to our National Advisory Council email here. And please see the Federal Register notice if you have any more questions or more details about that. And nominations are due by August 29th. We look forward to getting some new members as well, and we'll miss those who are rotating off as always. So I will turn it over back to Edmondo for the next slide, Jen.
Awesome. Thanks, Jamie. So a couple things. One, I'm going to take a little cherished privilege here to make a note about Dr. Schwartz. As Sandy was for many folks in this space in health services research, but for me personally, a mentor for the last couple of decades. Literally, I owe my career to Sandy Schwartz. Literally, his connections throughout the industry, throughout the country, and his just one-on-one, warm but very probing approach to mentorship I personally benefited from. And so I would be remiss if I didn't comment on that. It's a really big loss for me personally, and I think really for all of us.
Armando?
Yes.
Yeah, it's Lee Fleischer. I just wanted to tell the group that I just sent Sue Schwartz the fact that you gave him his tribute. She was incredibly appreciative and actually would like to hear it. So, but I wanted to tell the group that it meant a lot to his widow.
Good.
Thanks,
you.
Lee. We'll make sure that happens.
Yeah, appreciate that. On the next, so what we're going to do is let's talk about what the agenda is. It's a packed agenda, and really what we're asking for the NAC members is, and I don't think it's going to be a problem, but it's really an engaging agenda. It's one where there's going to be questions asked. There's really going to be an expectation around really kind of engaging around these really important topics here. So walking through here, we are kind of going through the welcome now. We're looking at an update on our programs and some accomplishments, which we'll do next. David come through with the budget opportunities. We'll talk about telehealth. We'll talk about some patient safety opportunities as well, and then a public comment prior to wrap up. So that's how we'll go through the agenda. All right, so for the AHRQ update, we're gonna what I'll do is I'll introduce the four folks who will be giving these updates, and then they'll go give their updates back to back, and then we'll take at the end a few clarifying questions after that. But let's go through the AHRQ update. So we'll get the update from Dr. Francis Chesley. Will be coming in as director of the Office of Extramural Research, Education, and Priority Populations, as well as the Office of Minority Health. Dr. Jeff Brady directs the Center for Quality Improvement and Patient Safety. We'll hear from Dr. Arlene Bierman, who directs the Center for Evidence and Practice Improvement, and then we'll I think last we'll hear from Dr. Joe Cohen, who directs the Center for Financing Access and Cost Trends. So I think it's Dr. Chesley gonna kick it off.
Good morning. Next slide, please. Next slide. So here we're highlighting recently awarded research grants. The Jiang project will address facilitators and barriers to consumer patient safety events reporting during care transitions and develop a patient-oriented patient safety events reporting system for cancer patients to engage in medication event reporting, promoting safety and quality of care. Kathleen Carey will conduct research examining the impact of the CMS Comprehensive Care for Joint Replacement model for total hip and total knee replacement surgery on safety net hospitals relative to other CJR hospitals by focusing in particular on improvements over the first 5 years of the program. And then finally, the VEST grant supports effective care by enabling provider access to clinical and social context information. The project will implement and evaluate a clinical decision support tool that identifies emergency department patients needing a referral to a social provider best equipped to address social needs. Next slide, please. And here we highlight three recent publications by our grantees. So 2 AHRQ-funded studies were published in the June issue of Health Affairs. Among small to medium-sized primary care practices participating in the Evidence Now initiative, Edwards found that zero burnout practices had higher levels of psychological safety and adaptive reserve, a measure of practice capacity for learning and development. Compared to high burnout practices, zero burnout practices also reported using more quality improvement strategies, more commonly were solo and clinician-owned, and less commonly had participated in accountable care organizations. The study by Liu and colleagues from the AHRQ Comparative Health Systems Performance Initiative identified the potential for higher costs among practices participating in ACOs. And finally, AHRQ grantee Danielle Lavelli published insights from her team's effort to develop generalizable learnings that can support the integration of electronic patient-reported outcome measures into the clinical practice within a learning health system framework. 3 thematic areas emerged, including governance, recognizing the importance of leadership, integration, the intersection of workflow, technology, and human factors, and reporting. Let's have the next slide. The agency's authorizing legislation provides that AHRQ shall conduct and support research with respect to healthcare for priority populations. In May of this year, we updated our priority populations to align with the Biden administration statement on equity. The updated priority populations definition includes racial and ethnic groups, members of religious minorities, lesbian, gay, bisexual, transgender, and queer persons, persons with disabilities, persons who live in rural areas, and persons otherwise adversely affected by persistent poverty and inequality. Implementation of the updated definition includes ensuring that all funding announcements include clear guidance that research objectives must meaningfully include priority populations. We've also included priority populations in review criteria and performance metrics in each of the funding announcements. Next slide, please. Over to you, Jeff.
Okay, thank you, Dr. Chesley. Well, good morning, everybody. I'm pleased to be sharing updates about 3 resources that AHRQ has recently released to support practice improvement. The first is a new toolkit to improve antibiotic use in long-term care. We launched this on the AHRQ website last month on June 28th in conjunction with the Association for Professionals in Infection Control and Epidemiology annual conference. That's APIC. A group with which we enjoy some really productive collaborations. The toolkit is based on the experience of more than 400 long-term care facilities that participated in AHRQ's safety program for improving antibiotic use. And we're pleased to report that project resulted in a significant reduction in antibiotic starts. The toolkit is grounded in the 4 moments of antibiotic decision-making, and these are key milestones at which thoughtful, deliberative action can really optimize antibiotic use. So we're very encouraged by the additional improvements that are possible based on the availability of this toolkit. Next slide, please. Another resource that AHRQ recently released is a revised survey that's part of our CAPS collection of surveys and improvement tools. We developed the revised version in response to the growth of telehealth that we've all witnessed, and changes include new question wording to accommodate all types of synchronous visits, as well as a new look-back period. And here are some of the sample questions that are related to issues such as preparations for a telehealth visit, including things like instructions about the use of video and other information. For both video and telephone-based visits, there are questions about whether the patient was able to hear and communicate clearly, obviously important issues for safety and quality. This newest survey is currently designated as a beta version, and we intend that to indicate the availability for use immediately as we speak in support of quality improvement. For other uses, the survey still needs some additional testing and validation, as has been done for pre-existing core surveys for the clinician and group CAPS. Next slide, please. So finally, I'm pleased to share that AHRQ's patient safety team developed and released a new common format for event reporting that's focused on diagnostic safety events. As you know, improving diagnosis is an emerging area and a key priority for AHRQ. The Patient Safety and Quality Improvement Act authorizes AHRQ to promulgate standard data elements for patient safety events. And with this newest common format, our intent is to raise the visibility of these events, diagnostic safety events, for healthcare providers by helping them identify and report missed opportunities. We have our sights set on more widespread use, learning, and improvement based on this standard. And that goal is much more feasible thanks to organizations such as the Society to Improve Diagnosis in Medicine, who are collaboratively engaged in working with the field and us to make sure that the standard is useful. We just finished a public comment period on the draft version, and we'll be working to unpack and process those comments that we received, and then follow that by a release of an updated version in response to public comments. With that, I'll turn things over to Dr. Bierman.
Thank you, Dr. Brady. So good morning, everybody. So I'm going to spend most of my time telling you about our growing portfolio of work in dissemination and implementation aimed at improving practice. And the three initiatives on this slide build upon what we learned in our first Evidence Now initiative that enrolled over 1,500 primary care practices in 7 states and regions across the US. Now completed, Evidence Now achieved measurable improvements in performance on quality indicators of cardiovascular risk reduction. But more importantly, it provided rich evidence on how to support practice improvement in primary care, including the role of practice facilitation and the use of health information technology. Francis Chesley told you about the recent paper published in Health Affairs by Evidence Now investigators on zero burnout practices. And this is just one of many published and forthcoming publications from this initiative. So the approach AHRQ is taking with practice improvement integrates implementation science and quality improvement in order to provide the evidence on how to improve care. And in addition to implementing specific patient-centered outcomes evidence, each initiative aims to produce sustainable change in participating practices and generalizable knowledge on key aspects of care delivery. So our initiative on managing unhealthy alcohol use is implementing the recommendation of the U.S. Preventive Services Task Force for screening and brief intervention to identify and reduce unhealthy alcohol use, and an evidence review by the EPC program that found evidence for the use of medication-assisted therapy for alcohol use disorder in primary care. And in addition to addressing an important public health problem, we really aim to understand the best approaches for integrating behavioral health in primary care. And each of the 6 grantees is testing their intervention, and there is an overarching evaluation of the project. And then building on what we learned in Evidence Now, we have funded 4 state collaboratives in states that have the highest quartile of adverse and avoidable adverse cardiovascular health outcomes, such as heart attacks and strokes, to work with primary care practices on smoking cessation and hypertension control. And grantees are designing interventions to reduce inequities in quality and outcomes of care for cardiovascular disease, while at the same time building sustainable state capacity and infrastructure for primary care improvement. And they are building partnerships that include state agencies, including state Medicaid agencies and health departments, and are encouraged to develop linkages and alignment between primary care and public health. Our newest initiative, we actually have the funding meeting tomorrow, is aimed at improving diagnosis and management of urinary incontinence in women in primary care. And urinary incontinence is common and can lead to significant morbidity and negative impact on quality of life. An EPC evidence review sponsored by PCORI found evidence both for behavioral and pharmaceutical interventions, and a subsequently jointly sponsored stakeholder meeting with PCORI found a lot of enthusiasm for addressing this problem. And although there are effective treatments, UI is underdiagnosed and undertreated. It's one of the biggest causes of nursing home admissions. And to be effective, grantees will need to develop, implement, and evaluate interventions that link primary care practices, community-based resources, and specialty care. And many women with UI also have multiple chronic conditions, so they will need to develop strategies to improve care in the context of MCC. Next slide, please. So our evidence for our D&I program has been produced by our EPC program, which has for decades conducted systematic reviews of effectiveness and comparative effectiveness. Does X work? Does X work better than Y? And the recent JAMA publication, Acute Treatments for Episodic Migraine in Adults, from the EPC program, a systematic review and meta-analysis, was published with an accompanying editorial in JAMA on June 15th. And it's a really great example of the type of reviews we have traditionally done. But we created a learning health system panel to learn more about their needs for evidence. And they have nominated a host of topics for review, which I'll mention in a moment. but they're asking very different kind of questions, like how population intervention characteristics and context interact to achieve outcomes, patient experience and preferences, factors or combinations that are necessary for success. And response, we're using many different and really developing standards for different innovative synthesis methods, including realist synthesis, framework synthesis, qualitative evidence synthesis, and qualitative comparative analysis. And examples of these reviews that use these methods are on this slide. Next slide. So for brevity and time, I'm going to be very quick, but there's a couple of new environmental scans from our Division of Digital Health that I think will be of interest to NAC members. We have a project called CEDAR, CEPI Evidence Discovery and Retrieval, which is aiming to find AHRQ evidence, make AHRQ evidence more fair, findable, accessible, interoperable, and reusable with our many resources. I saw one of the NAC members said, people don't know what we do. So we want to make it easier to find these very seamlessly on our website and integrate them into the digital ecosystem. And so the link is there for that evidence review. And also they did another one on integrating patient-generated digital health data into EHRs in the ambulatory setting, and are in the process of doing a toolkit for that. Our EPC program also recently released evidence review on patient-generated health data. So there should be some information in your packet about that, and I encourage you to look at that and feel free to reach out with questions. And I think I'm going to turn it over to Dr. Joel Cohn.
Thanks, Arlene. We're being very formal today, but just call me Joel. Next slide, please. So I wanted to talk a little bit today about a project that we've had over the last year, and it continues the theme of trying to make our data more accessible to folks. And it's a project we've had to improve the AHRQ data tools. And so we're trying to make the information more accessible and try to sort of come into the 21st century in terms of, the way we present information. So certainly data visualizations and that kind of thing are very popular these days, and make it easy for people to understand what's going on. So we have, done some work trying to make things more accessible. So one of the things that we've done, we put out a set of data, monthly hospital trends or trends in hospitalizations. We have data from the HCUP project over a series of years. And we also have quarterly data that we've tried to put out. So recently we put out the monthly trends. This, one of the things that we just put up this week actually was this data visualization site. You can see sometimes the problem is that sometimes the way we put our data out, it's a little bit hard to pick out, what you're looking for. Often it'll be in the form of a bunch of tables. You have to figure out which table you want. You have to figure out which number you're looking for. You have to figure out how to compare it. And if you're really not that facile with, statistical programs or, Excel spreadsheets and that kind of thing, it can be difficult to find what you're looking for. So we're trying to make it much easier for people to find what you're looking for. So on this one, you can see on the top, you can pick, what comparison you want to make, COVID-19, other conditions. You can select states. You can select characteristics of patients or stays. And then on the second line, you can pick a particular outcome. So number of discharges, in-hospital mortality rate, average length of hospital stay, et cetera. So here we've picked out a particular state, New Jersey, which is one for which we got quarterly data through the end of December. And so we had COVID, and we're looking at COVID as well as surgeries and elective admissions. So you can produce this graph, which I think is kind of interesting, because if you look over on the right side there, you can see when the COVID discharges are peaking, starting in April of 2020, you'll see the surgeries and elective admissions are declining. And as the COVID admissions are going down, the surgeries and elective admissions are going up. And then as that goes up again, those go down. So there's really a relationship between what's happening with COVID and what else is happening in the hospitals. Next slide, please. So that was specific to the hospitalization trends, but we also have an overall project, which is called our AHRQ Data Tools project, and we have this site that's up, but is still under construction. And again, we're trying to make it more easier for people to get access to our core databases. And in this case, we've started with MEPS, HCUP, the Quality and Disparities Report, and CAPS. And so some of this is up and some of it is still under construction, as you'll see in the next slide. But again, as you get into the site, if you know what you're looking for in terms of the database, you can go directly to that, as you can see here. Or in the last slide, you could see that there were topic areas that you could pick. So you can sort of get into it in different ways. But here you can pick, we have the MEPS and the QDR, and you can see the MEPS, we already have put up some information into the system, and the QDR we're still working on. But just to show you how this works, if you go to the next slide, I will pick here, I clicked on start for the MEPS insurance component. So then you'll get another screen which says, well, what do you want to look at? You want to look at private sector data, you want to look at private sector state data, you want to look at the public sector, et cetera. So here and then if you go to the next slide, I've picked the private sector national data. And again, you get a set of customizable selections. So, you can pick the estimate you want, you can pick, the categories of, firms or, groupings that you want to look at. And here I've looked at the average total employee contribution for private sector health insurance offered by establishments. This is the national one. You can do it by firm size or other characteristics, et cetera. But this just looks at it from 1995 to 2019. And as you can see, there's been, if you think that your out-of-pocket contribution to your private health insurance has been increasing over time, you can see evidence of it right here. That's very consistent with what's happening. In 1995, it was about $1,300, and in 2019, it was almost 6,000. I think it was about 5,700. So, so you can see what's happening there. Again, you can pick, the different characteristics. The IC is a good one for this because actually, if you go to the IC website, it's a set of like hundreds of tables with titles that are a little bit hard to figure out. So this makes it very easy to go in and pull out the kind of data that you're looking for. And we're trying to create some consistency across our different projects as well, so that people will be able to get into the website and pick what they're looking at. So you can go on the AHRQ website, and under data, you get a list. At the bottom, it says AHRQ Data Tools. I would encourage NAC members to go look at this, to play around with it. If you have comments, please let us know. And with that, I'll turn it back over to Edmonda.
Great. So really great update. Ton of information there. I know there may be a couple of clarifying questions, but we're going to move on to have David update us on the budget, and then at the end of that, we'll take a few questions. So David, you want to take it over from here?
Thanks, Dr. Robinson, and thank you all for joining us, especially to our NAC members, but also to members of the public. We had an opportunity earlier this year to brief the NAC on our budget overview. However, we can't take feedback from the NAC unless we do it in this kind of public forum. So I'm very happy today to provide everyone here a brief overview of the FY 2022 presidential request for AHRQ. We'll do that quickly, and then I'd love to invite the NAC not only to ask questions of Francis, Arlene, Jeff, and Joel, but then also to me about, and to give us advice, actually, the NAC members to give, so questions for them and advice to AHRQ on where we move forward over the next year. So thank you very much. Very importantly, the president requested an independent agency with core areas of health systems research, improving care delivery, and data analytics resources, which is what AHRQ is. Our budget is a $52 million increase over FY 2021, sharing the, it was exciting for me to see that the president and the secretary of HHS share our enthusiasm and belief in the importance of AHRQ's work. $489 million total, made up of a combination of appropriations and transfer from the Patient-Centered Outcomes Research Trust Fund. Next slide, please. If you wanted the cheat sheet, this is it. These are key points that I found in our 2022 budget. We have substantial increases in this budget for investigator-initiated health systems research, both new research and some targeted research, which I'll highlight in a moment. We have been part of the department's work on addressing the opioid epidemic for over 5 years, but this year the department is doubling its investment in AHRQ's work in this area, mostly in the form of new research. We also have woven throughout this budget our commitment to advancing equity and putting money where our heart is, looking at research, resource development, and improving AHRQ as an agency as well. For the first time, AHRQ receives funding dedicated for primary care research and primary care, supporting primary care implementation and improvement. AHRQ is part of a larger HHS initiative to address maternal health and the maternal health disparities in this country. And interestingly, while we are already doing work in research and doing work in improvement, this opportunity for AHRQ as part of the larger HHS initiative focuses on our data and analytic capacities. Finally, there is throughout the budget continued focus on our core business in patient safety and funding for new patient safety learning labs, as well as support of our foundational databases, MEPS, HCUP, and programs such as the Evidence-Based Practice Center program, our digital healthcare research initiatives, as well as our support of the U.S. Preventive Services Task Force. Next slide. In the interest of time, I'm going to flip through these very, very quickly, but know that they're there. People can go back and look at them, and the NAC members have seen these before. But over half of our increase in budget goes directly into research dollars, health systems research, both increasing our amount of general investigator-initiated research funding, but I wanted to highlight $5 million to understand how health system innovations responded to the COVID-19 pandemic and to help evaluate them and understand how to continue to move that work forward in the future, both for recovery as well as continued resilience. And then a new initiative, $3 million in research funding to support health systems in evaluating their work to increase the equity of the care they delivered. Additionally, $1 million in funding for AHRQ for the first time to be able to offer diversity supplements, which help us create a more diverse health services research workforce. Next slide, please. We also received funding, as I mentioned, for our opioids initiative, $7 million in new research grant focusing on equity and treatment with a focus on primary whole person care, as well as I mentioned, money for primary care, $5.5 million into understanding new models that deliver both individual and population health with a focus on equity, as well as $3 million in infrastructure grants to support primary care practice-based research network, something that we were actually founded in our original authorizing language to do, but have taken a step back from in the last few years. I'm very excited we will move back into this space. There's also an additional $1.5 million for implementation contracts and supporting those who help primary care improve. Next slide. I'm going to go through these quickly, but I did want to remind the NAC members and everybody else here that we will only be as successful with this funding as the quality and the quantity of the applications we receive. So please help us spread the word that this is a great moment for teams to be thinking about what their projects should be and preparing their applications and even submitting them now so we can fund them next year. Next slides, please. We'll go through these very quickly. As I mentioned, we're part of the Maternal Health Initiative with a focus on helping federal, state, and local policymakers have timely and accurate data and useful analytic resources concerning maternal health. Next slide, please. Advancing equity, we're taking a multi-level approach at the bottom here as a foundation, making sure that AHRQ is an equitable and just place to work. So investing in diversity, equity, and inclusion projects here. We're taking a look across the agency at our tools and our resources, our policies, and our procedures, and improving them. So we help drive health systems and the health service research community to improving equity. And also those grants that I mentioned, both supplements to promote diversity in the workforce, as well as truly understanding equity in delivery. Next slide, please. As I mentioned, all of this budget allows us to continue all of our priorities. Patient safety, we'll hear a lot more about that in a moment. Our data and analytics work, which we just heard, including the second year of sample expansion for MEPS, which we're very excited about, some increased funding for our working CAPS, as well as I mentioned, the maternal health initiative is a real focus on expanding both our data and our analytics abilities. Next slide, please. This budget is very much aligned with the new administration and the leadership here at HHS. It's also consistent with the independent RAND report on the future of health services research, which Congress asked us to commission, really keeping AHRQ as a focus in the department on improving healthcare delivery. It also involves funding to help us learn from COVID-19 to advance health equity, addressing the opioid and what we recognize as a polysubstance abuse crisis, as well as improving maternal health. All four of these are areas of focus for the current administration and department. We're also very, very excited, as you just heard from Arlene, and I'm very happy to see in the comments, a real commitment to AHRQ's special role in advancing primary care and primary care research, which is not only consistent with the findings of the RAND report on the future of primary care research, but also is consistent with the recent National Academy of Science, Engineering, and Medicine report on implementing high-quality primary care for all Americans. And finally, AHRQ will be using the Peace Corps Trust Fund to continue our work in dissemination, implementation, and training. Next slide. Speaking of that trust fund, this is what we invest in. But I wanted to remind everybody, we are in the middle of a major strategic planning process to align our future investments with both our priorities, national priorities, and the department's priorities. And thanks to the NAC, we'll be having a subcommittee of the NAC to help us provide external stakeholder input into the strategic planning process, as well as many other opportunities for the public to engage with us on this. So look for that in the coming months and year. Final slide. This is a budget roadmap. The budget itself was proposed by the president this spring. It's been taken up by the Congress this summer. The House actually, the subcommittee on health just approved this budget level for AHRQ. We're very excited to see that this week. And we expect later this week, the full House committee will approve the full HHS budget. And so that's a nice first step, but it's still a long process and there may be changes as the budget moves forward. But we look forward to using this opportunity to move our mission forward and achieve our goal of improving the lives of patients. Next slide. To do that, as Arlene mentioned in the chat, I wanted to let you know, we are not waiting. We are already staffing up on many of these priority areas. I'm ecstatic about the quality and the experience of people who are interested in joining the AHRQ team. These are all people who've joined us within the past 6 months. You can see across the agency, we are building up. Next slide. So now, happy to turn it back to Edmondo and the NAC to talk to us, but we'd love to hear a little bit about who you think we should be partnering with to help us ensure success. What other opportunities you see that we need to be taking advantage of in FY22, and thinking ahead, if this budget is passed, what should we be looking forward to be doing in 2023? Where's the long game here? And finally, as always, we appreciate the NAC helping us understand how do we have the greatest impact to improve the lives of Americans. And with that, I'll turn it back to you, sir. Maybe we can
Awesome.
even take the slides down.
That's certainly great news. And so, that's a great way to start the conversation. I think the vote of confidence from the administration, from the president is very encouraging. And now we're left with, now we have to go get it done. right? And so what the role of the NAC is around these questions, these probing questions that David has laid out here is, how do we go about doing that? So what I'd like to do, I have of course comments myself, but I'd love to hear from the rest of NAC as well. If you want to shoot a note into the chat, I can grab some of that and then pull that out and call on you specifically. If you want to kind of do our hand raise Zoom thing, I can do that as well. We can kind of make it work in this digital age here. But one thing as you were presenting, and of course, David, we've talked about this before, we've had another meeting, but it occurred to me again, and maybe this is, maybe we've talked about this before, but I'm thinking about especially with the presentation right before your budget presentation, I'm thinking about the intersection of the strengths and competencies within AHRQ in terms of how to focus some of this, some of the new energy, right? So you look at the focus around equity, you look at patient safety, you look at primary care, and say something like your new digital center, and you pull that together, right? And you pull those competencies and that expertise together around topics like, again, equity, safety, primary care, digital. I'm sure there's other combinations like that where you're actually pulling in expertise across the agency. It could be really powerful to leverage that and to leverage this kind of budget around something like that. So that's just one idea that occurred to me. But
so Armando, just watching your hands, I realize we're a Rubik's Cube. Sometimes we twist it to get health services and practice improvement and data aligned across something like patient safety. Sometimes we look at telehealth as a tool for moving across hospitals and patients' primary care and specialty care. We can figure ourselves to bring our competencies to address many questions. So I'm going to get our team in OC to help me with that graphic.
That'd be awesome. I think I see Ram's hand. Yeah.
Thank you, Edmundo, and thank you for the great presentation. My only caution will be that as we are doing the innovations in the post-COVID and getting ready for another COVID-like pandemic, we just have to have a commitment for the healthcare delivery system. Normally what happens is we have this funding, they come with innovation, then after 1 year, everything goes into a shelf and people don't really invest on excess capacity because they go back to business as usual. Then another thing hits in another 5 years, then we reinvent the wheel all over again. So I think if you want to award some of those grants, we must get a commitment from the health institutions that will be an ongoing commitment on the part of them to keep this innovation going, as opposed to just one shot and then people are back to normal as they are.
Wise counsel, thank you, Ram.
Yep, makes sense. Youngling, I see your hand raised.
Thank you. One thing I thought would be good to see AHRQ based on the model that we have, developed during the COVID pandemic, to develop the building a more robust and transparent reporting system on all-cause harm, like infections, medical error, patient safety, in real time. Because from lesson we learned and what we have done with infection during the COVID, we can put the data out to inform the public and policymakers, public health, agencies on what is going on, and rapidly develop policies, to tackle the problem. And I think that we should, have a focus on that. And I would like to maybe later have an opportunity to talk about building a patient reporting system, why it's so important. If time allowed later on, I can elaborate on that. Thank you.
Absolutely.
I want to say, maybe pairing with this opportunity to pairing the safety and equity, put a lot of focus on the priority population. because they are closely related to safety and equity. Thank you.
Other thoughts? Well, I have another one, David, just because, you know. And I know you've thought about this before, and we even talked about it, but I feel like it's really important, especially in this meeting with all of the folks that are online and listening in. I think what's going to be really important is collaboration across the department. And so, and again, you know, we're not saying this is not something that's unknown, but I think what's really going to be critical is defining the roles of each agency by each initiative that you're really trying to collaborate around. Right, so much so that, you know, again, this is a tool that I certainly use is even race each other. Right, and understanding like this is the competency that we bring to the table. Who's going to be responsible? Who's going to be accountable? Who's going to be kind of consulted, and who's going to be informed around any particular initiative that you're really trying to collaborate across. So there's absolute clarity, and that allows you to optimize your resources, bring the right competencies and right expertise to the table, without redundancy, and with plenty of clarity. I think a skill set around actually that kind of collaboration, I think will actually accelerate the work that you're doing. Again, when you're again collaborating across the department.
So thank you for that, and I'll take all the extra thinking you just gave there, and we'll continue to think about how we can best help the department do that. But for everybody on the NAC and listening in, I do want to assure you that this administration, and specifically HHS, is in a very collaborative space right now, and is really thinking hard about those questions about the roles and the partnerships, breaking down silos and learning together and implementing together. And that's been necessary because of COVID, but it continues to be important. We've seen how well it works when we work together. I think some of my colleagues at AHRQ may be tired of how much cross-management we are doing, but I think it is very, very important. And I agree, Edmondo, that AHRQ has to be very, very strategic about what are the true competencies that we can bring to the table, and be, given that we're small, not overextend ourselves and have the greatest impact. So we'd love to hear from the NAC about where you all see those opportunities as well, but we will continue to try to do that.
Exactly, makes sense. Chris, did you have your hand up? Just checking. She's just waving.
I saw a soft name, but then he didn't ask the question.
Oh, I've been chatting into the chat function, just the excitement, you know, around this agenda, the expansiveness of the agenda, the focus on inclusion, the focus on health systems of the future. You know, my interest, the focus on revitalizing the critical aspects of our primary care system, and I just I'm excited, and you know, David's known me a long time. I'm an optimist, but I'm not always excited, and now I'm both optimistic and excited. So this is wonderful.
That's terrific. I want to make sure, oh, Chris, but I also want to make sure NEC members, if you had questions for, and I'll use first names, Francis, Arlene, Jeff, or Joel, they were a little behind, so you're welcome to bring those up as well.
Sure. So very quickly, and I apologize, I was actually looking at the email because I sent out our questions to a number of my colleagues who had thoughts about what they thought AHRQ should be doing on it, and I didn't want to misquote. I think one of the things that came up was the interest in collaboration is huge. The opportunity and the focus to get the private sector more involved in AHRQ work. Someone commented and said, they're really interested until we talk budgets. And so I think trying to figure out how to maximize ways to engage the private sector when in fact there are limited budgets for the AHRQ research that we do. And by the time most organizations deal with indirects, there's very limited amount of funds to support salaries. So I just just the how do you make that happen? It's exciting that the appetite is there, but the how-to is confusing. And then another piece that I brought up earlier in the chat that no surprise comes from our huge human factors and engineering group is to look at the opportunity for funding work in the realm of resilience engineering. So trying to understand when things work well in spite of huge variation and conditions that we would normally think would be confounders and lead to, I'll say, less than ideal outcomes. But so that focus on how do those who do it well do it, that would be an area for additional looking, if you will, in our patient safety work. And then finally, the last, not the last piece of information that I got, but I think another piece that fits in with this general conversation is the notion that that AHRQ continues to expand its portfolio. And again, I put a little bit about this in the, and some of what we saw in terms of the website is just breathtakingly a step forward, but really having all those new energetic brains at AHRQ get together and help figure out how to get the word out. Because word of mouth is great, but there aren't enough of us with enough contacts in one question leads to another. The last thing I would say, and again, I stuck it in for Dr. Cohen, is that when the AHRQ announcement came out about data visualization for HCUP, I got 3 emails from people that I didn't even know, who know that I'm on NAC, who know that I do AHRQ stuff, and said, oh my gosh, they're coming of age, data visualization, this is great. So I do think people notice, and so more of those sorts of public service announcements, if you will, that as AHRQ take steps forward, that you announce that you're taking steps forward. Great stuff, very exciting.
Oh, thank you, Chris. That's all great. I'm glad my team is here to hear all of that.
David, I'd like to pull one comment in that came in through the Q&A around this idea of, and it's really a kind of extension of some things that Chris was saying, which, you know, this idea of public-private partnerships. So really thinking about how do you extend and accelerate the reach and impact of the work that AHRQ does by leveraging kind of more of the private partnerships. And so again, you're going to run into, you know, the challenges that Chris has already articulated, but you know, the opportunity is so vast there that I think special attention to that. So I agree with the comment. Essentially, special attention to that really is critical. And AHRQ, of course, has a long track record of collaborating in that space. And so it's really more of that is what it sounds like to me.
Okay, we hear you. I think there are enormous opportunities. And for those of you on the NAC who have real experience in how to build those, there are some federal limitations, but those they're not absolutes. They're just checks and balances. So if you have ideas about the best ways we can build private-public partnerships to move things forward, we are ready to go. There are many people at AHRQ and some of the new folks that we're recruiting that are helping us think that through. So please add your ideas so we can make that happen. Jamie, how are we doing on time? We have about 5 minutes?
Yeah, we're good on time.
Yes, we're good.
Yep, just making sure.
And one thing, since I've got a second here, I do want to encourage folks. I see Young, I see you, man. I do want to encourage NAC members, if you can, and trust me, I understand the technical difficulties, but if you can jump on video, partly so I can see you and see the members, and so it's a different way of engaging. You know, it's challenging. It looks like, you know, we'll be in person for our next meeting. But you know, that's I don't make those calls, so but you know, I'd like to be able to see you guys and kind of pull you guys into the conversation. So thanks. Emily, go ahead.
Yeah, thank you. In terms of talking about the partnership, I think it would be important for the agency to also develop the partnership with the patients and consumers. I think they are a very critical part of the stakeholders. And they may not be able to do research, but they can participate it because the research and recommend guidelines out, medical guidelines is a strength of AHRQ. So that rely upon data, and patients are important, consumers are important source of data. And I've just gratefully touched, the patient reporting. And I think, many studies have shown patients and family members can identify over 80% of adverse events, hospital-acquired conditions, and diagnostic error. So those very important source of data that had under-tapped. So I think, if we have money, I would say agency develop a registry, sort of like a modeling the FDA events reporting, that we can tap into this resources from patient consumers and to bring into the collaboration with the agency to provide the data and then report that we can have a general hospital-acquired condition survey, or have the target like a diagnostic error registry reporting. And Bessie Lemon did a study just recently on the medical error impact on patient harm. It's not just the resulting harm, but also emotional damages, economic damages, long-lasting health condition. But they only did for Massachusetts, I think. But AHRQ could do this with the resources to do a national survey regularly to monitor what's going on with the patient safety issue, with the impact on different populations. I think that you have done a lot of this work, but more systematically, that is one way to bring the consumers and patients, this big stakeholder, into the the collaborations to improve safety and quality.
Fascinating idea. We'll continue to turn that over. That's the kind of out of the box thinking that we love to hear. I would say that our patient safety team at AHRQ has been some of the earliest adopters of full engagement of patients and families in improving patient safety. And you're going to all get to hear a little bit more about that after lunch. We'll continue to do that. It's also where we developed our CAP survey. So some of the first work of having patient experience incorporated into the improvement system, both in quality and in safety. Our work in CEPI is looking at how to capture patient-recorded outcomes as part of the healthcare data infrastructure, which I think is another key piece of truly engagement. And we've actually asked and are starting internally at AHRQ to think about how patients and consumers and families and communities can be part of our research system and our research review process as well, to be better represented, to make sure that we're asking the most relevant questions. So, but thank you for the reminder and the challenge.
Yeah, really, I agree, David. Really interesting. And I love the idea. So we're going to talk patient safety and doing a deep dive a little bit later today, but I love this idea, and the numbers look great. We're really making strides in terms of, for example, hospital-acquired conditions. Really be fascinating to understand the impact around mental health, the impact around the financial impact, not just to the system, but to the patients themselves and their family members. I don't know that we've ever kind of looked at it from that lens. I just think it's a great, really great point. I think it's a fascinating area to explore. Go ahead, Asaf.
Just a couple of thoughts building off of that, and there are two buckets of thoughts, but building off the last comment, I think one of the exciting areas that really combines sort of patient-centeredness with patient safety improvement at a systems level is this area of work, and I bet AHRQ has invested in it or had some part in it, around communication and resolution programs. So, programs at the health system level that aim to systematize and make it easier to do the right thing around adverse events, errors, reporting, communication, and resolution, which includes sometimes communication and sometimes, financial or other kind of malpractice area, sort of transparency and resolution issues. The key part is not in that any of this stuff is new, which it's not, and you've invested in this research in years, but it's rather that bundling together and that measurement capacity and the C-suite leadership capacity that helps engage systems in, as I say, making it easier to do the right thing all the time with patients and families who have experienced adverse events. Happy to talk further with folks about that as we do some work with, as do many others on that at the health system level. So that's one area I'd love to see more about. And in that theme of bundling together the things that we already know work and testing those bundles at a systems level. The other area, and David, you and I have talked about this over the years, but it's just a question, and maybe there are reasons for this that can't happen, but so much work comes out of CMMI and so much data comes out of CMMI, and there are evaluators and evaluator contracts, but yet there still are areas of work and investigation that I still do wonder if independent investigators or consortia of investigators can perhaps be funded to look at data that wasn't in the actuarial or sort of federally mandated evaluation, and that has sort of innovation potential. So just wondering if that, I'm sure there's enormous complexity, and I still ask the question, is there overlap in this area?
So Jeff already put it into the chat, so I hope everyone will take a look at some of our work on communication and conflict resolution. But I think, Asaf, I heard you saying, yes, we've done that and we have packaged it, but how do we spread it even further? And how do we bundle it with other things? And how do we engage more systems and really think about changing the way many, many systems use it? So, great. I like it when you make me feel uncomfortable. These are hard questions, but we can do that. Your second one made me feel even more uncomfortable, but the importance of partnership between AHRQ and CMMI. For those who don't know, Center for Medicaid and Medicare Innovation, run out of CMS, doing very large scale payment initiatives to improve quality and safety, both in Medicare and Medicaid. It's a natural partnership for AHRQ. We develop the evidence, they can develop the financing to support it. And you've just asked the question, can we build better systems that when they collect all this data, they have to move on and they have to go to the next one, and they have are there ways AHRQ could support them in digging deeper and finding more lessons and more innovations that could help the next model? I think it's the exact right question to ask. You're right, there are reasons, but I'm glad our colleagues from CMS are here and we will continue to think about that. So again, thanks for making me feel uncomfortable.
So David, what I'd like to do is give Greg the closing comment / question here, and then kind of move on to our next topic.
Absolutely.
Yeah, so thanks for all the comments. So as I was listening and thinking about what's happened over the last year and a half with COVID and the major impacts on the healthcare system that have occurred, I don't think there's been really, well, I mean, every sector of healthcare have been impacted by it, but I think the long-term effects of COVID on sectors like long-term care are not ever going to go away. There's always going to be this fear of infection, the fear of the next isolating event where people are literally almost trapped in a facility and can't get out because they don't want to be exposed to the next virus. And I'm wondering, there's been a massive spread of telehealth and the use of that in those sectors without really any evidence to support how it's been used, because it's not been supported through funding. It's not been supported really through other initiatives for a very long time. And it's been supported in other sectors, but long-term care is very unique in the delivery of care. And so I'm wondering if some collaborations couldn't be developed and thought out through organizations that support long-term care, like Leading Age, or AHCA. I mean, there's many organizations that support long-term care initiatives and support patient safety and health IT and all of those things. But I don't hardly ever see any sort of initiatives to support their engagement, and, you know, in building better systems through AHRQ or other forms of funding. And I don't even know what that might look like. But if you engage those top level organizations that the homes participate with and pay money to participate in to generate data and generate information about better systems and evidence-based practice, there could be some real synergies that develop out of that really impact hundreds, if not thousands of homes, because those organizations have a major impact there. And they have a real interest in drawing in patients and caregivers in the community. And I would even encourage you to think beyond the nursing home to those organizations like assisted living organizations that where assisted living facilities belong to an organization, because there's a big shift. You know, I think people are afraid of nursing homes now, they want to be in the community where they live, and I just think there's an opportunity because of COVID to continue that movement, and to understand it better. Really high and low performing things like organizations like Chris talked about really applies to long-term care as well. And so I know there's some initiatives that AHRQ have with long-term care, but you know, you asked me to be on NAC, so I keep beating the bandwagon about this because I think it's sometimes an area that's forgotten.
Greg, I look forward to potentially coming back to the NAC with some of what we're doing in long-term care in the chat, and maybe Mammoth, if you have a moment, you can type a link, or Jamie, to the work that we were able to do over the past year. But you're asking all the right questions and pushing us in ways that, and I promise you, we are really thinking about what the next phases are. We reached out and worked with over 9,000 nursing homes during COVID. But as Susan and others have pointed out, one of the things we discovered is and actually our colleagues, and we tried to coordinate with our colleagues at CMS who had another approach, and we're going to try to learn what works for whom and how. But the lack of safety systems thinking about infection control. AHRQ has all sorts of knowledge and tools and practices, and how do we partner with these people that are doing really, really hard and important work, often with short staff. How do we empower them? And through partnerships, but that's for another time. And I will, but there is some good news, and thank you for keeping us honest on that, or moving forward. Dr. Robinson, I saw Susan had a question, but I know the telehealth team is raring to go, and it's going to be really, really great.
I know, and we're behind time. So Susan, I'm going to have to hold you for now. We will have the telehealth time. Actually, is an interesting segue from Greg, because he mentioned telehealth in the setting as well. So I think Jamie and Keith can bring some of that up. But Jamie, I'm going to hand it over to you.
Super. Thanks so much, Edmondo. I'll just to say thanks again for bringing us up, and for Greg for kicking us off and really setting us up for this conversation. Jen, next slide, please. I'll say our goal for this session is really just to give you a highlight of how we've been thinking about telehealth here, and really have more conversations with the NAC members about where we can go and how we should focus. And so obviously, since the pandemic began, we've all witnessed this surge in telehealth that occurred. And obviously prior to March 2020, telehealth claims in the United States grew at a very slow rate. And with the onset of the COVID-19 pandemic, we saw an abrupt spike in telehealth claims in the spring of 2020, followed by a kind of a gradual decline and leveling off by the end of December. And this particular data set is showing claims for the private insurance market. So Jen, next slide, please. But even in the Medicare fee-for-service, the primary care telehealth office visits increased 350-fold for Medicare fee-for-service beneficiaries during the public health emergency. And while we've seen that more recent data is showing a decline in telehealth for some areas of medicine, Some services seem to be holding steady at the moment, including mental health and behavioral needs. Obviously, there's just been an increase in telehealth. Next slide, please. I think many of us here know that most of this increase occurred because of the Medicare flexibilities, and Medicare added over 100 of new virtual telehealth services. It expanded the list of eligible providers and allowed for services to be rendered in new settings during the public health crisis. And I just want to emphasize here that evidence provided by AHRQ's EPC reports contributed to CMS making these flexibilities. Next slide, please. But as we heard from Greg, this increase in telehealth has raised many questions that have yet to be unanswered. And so while AHRQ has been doing work in the telehealth space for many years, we at AHRQ really took a hard look at our expertise and capacities in this area to increase our focus on telehealth and identify ways that AHRQ could contribute to answering the important questions that this real world experiment was generating. And it was about a year ago when our director at the time, Mr. Gopal Khanna, wrote a blog about the importance of telehealth and about AHRQ's foundational work in this field, funding the Extension for Community Healthcare Outcomes, Project ECHO, which I know was mentioned in the chat before, but which is a telehealth mentoring approach that brings expertise to patients in medically underserved areas. And since that time, telehealth has dominated our AHRQ blog topics, including one published by NAC members here, so thank you. We've also heard from leaders in health systems about how their organizations had to adjust overnight to this rapidly increasing demand. And we also heard from many of you throughout our NAC meetings and the year about how this rapid expansion of telehealth during the pandemic has created both historic opportunities and unique challenges to answer these important questions. And obviously the answers remain, questions remain unanswered. Next slide, please. And this is why I am very excited to introduce you all to my colleague, Dr. Keith Cannell. Keith is new to AHRQ and serves as Director of Division of Practice Improvement within the Center for Evidence and Practice Improvement here at AHRQ. I'll let you read more about his bio on the information that was sent out in the interest of time, but I can assure you that Keith has a very impressive resume. And at AHRQ, Dr. Cannell oversees a diverse portfolio of implementation and dissemination research initiatives ranging from frontier practice improvement to integrating behavioral and physical health in primary care. And Keith is also serving as my partner in crime here at AHRQ as co-lead of this telehealth across our agency, because we've really been thinking hard about how to work across our offices and centers here at AHRQ. And so together, Keith and I have an extraordinary team at AHRQ and are working together across our portfolios of work in telehealth and across our core competency areas in research, in health systems research, practice improvement, in data and analytics. And we also are working across the department through a number of internal working groups and with external stakeholders to kind of explain AHRQ's work in telehealth and really to position ourselves to be most impactful in the future. And so with that, I'm going to let Keith tell you more about the work we've been doing and then be able to get to a really important conversation. So with that, I'll turn it over to Keith.
Thank you, Jamie. Next slide. First off, let me just say that being rather new to AHRQ, today I will be presenting the work of a lot of amazing people who I now have the privilege of calling colleague. So for that, I am very, very grateful. When we convened the telehealth work group, the first thing we did is, to Dr. Robinson's point, is we wanted to make sure that the work we did was scalable and comparable to other players in DHHS. So the first thing we did was define telehealth to make sure that we were aligned. And this is the case definition that has currently been adopted by HHS and is used by the Interagency Policy Council that's dealing with telehealth right now. And that is, telehealth is the use of electronic information and telecommunications technologies to provide care when the patient and the doctor are not in the same place at the same time. This is obviously an expansive definition. It does capture the fact that telehealth can be asynchronous, which is important, and it does emphasize these are electronic platforms we're talking about. It's not perfect. I think that we know that there are providers beyond the doctor that will meaningfully engage in telehealth. But this is very helpful for us to frame our policy and research initiatives. And I can tell you that although we're probably talking about dozens of platforms and modalities, the discussions typically revolve around the five topics that I have on the slide here: video office visits, audio only, store and forward, which is asynchronous telehealth, apps or mHealth, mobile health, and remote patient monitoring. Of these, I think most people regard video office visits when they think of telehealth, but know that in policy circles, it's the audio only topic that is really driving a lot of vigorous discussion. Audio only, which is essentially covered telephone health, has been extraordinarily important at expanding access, especially during the public health emergency. And it's helped buoy up practices economically as they've been switching to telephone as their main vehicle of communication. That said, I think when we look at this from a federal standpoint, there is a fair amount of overuse and misuse in this area too, that we're just finally getting our arms around. So the discussions span all these topics, but they are somewhat focused. And next slide. Someone did ask for an example of store and forward. Just a couple are images that are transferred through telehealth. X-rays, biopsy reports, for example. But a really interesting one is this notion that we don't have enough psychiatrists nationally. And what we could do is begin recording psychiatric interviews, and psychiatrists could look at these in an asynchronous fashion to provide care in underserved areas. Going back to the telehealth, we did look at, we have to acknowledge that AHRQ has a very strong legacy in telehealth, and it does begin with Project Echo in 2004. And for those unfamiliar with the details of Project Echo, this is where a single research group in New Mexico was able to coordinate and provide antiviral therapy for hepatitis C patients in primary care offices and prisons across the state using a hub and spoke network. It was incredibly successful, and it generated outcomes that were actually on par of the academic medical centers in the region. So the playbook was cast, and we've been attempting to build on that over the year. The results were published in 2011. Also in 2011, the federal government began pulling together players in telehealth, and the Federal Telemedicine, or FedTel, work group was formed. It's about 30 agencies that are all together on a bi-monthly basis to exchange ideas, to keep everybody apprised of their developments in telehealth. We were privileged to be able to present the work of AHRQ at the FedTel presentation on July 1st. So I think we are definitely part of this community. Jamie did talk about AHRQ's telehealth evidence reviews. They were important, and we have been very active in this area. I've listed on the slide here 6 topics that have been released just in the last 5 years. The evidence map, care and diabetes, acute and chronic conditions, strategies for patient and family engagement, telehealth expansion during COVID-19, and PGHD, patient-generated health data. In November, HHS did convene a working group to talk about where we stood in telehealth, and as Jamie pointed out, the top 5 evidence reviews on this list were at the center of this discussion. Lastly, the AHRQ has established a digital healthcare research division, and that has provided a framework and a funding source for investigators in telehealth. Also a community by which they all can learn. Next slide. When we assembled the work group in 2021, we decided in this past winter, we decided to first off methodically enumerate our assets in telehealth. And we spent a fair amount of time doing this. We wanted to align our assets with our 3 core competencies of health systems research, practice improvement, and data and analytics. Under health systems research, our 2 top assets are the evidence reviews and digital health care research that we've just spoken of. Under practice improvement, Project Echo has been modernized, as other speakers have mentioned, and we'll touch on that very briefly today. Our primary care implementation research that Dr. Bierman spoke of, Evidence Now, does not have a very specific telehealth focus, but in the spirit of implementing better solutions in primary care, telehealth is obviously part of the greater picture. And we've begun through our learning communities to understand this more. Patient safety critical in advancing telehealth, so we make sure that we don't cause unsafeties in any way. And the PSNet led by CQUIPS has been very, very helpful in that area. And lastly, we've talked about CAPS and MEPS under data analytics, two legacy tools of AHRQ that have both been configured newly for telehealth application. Next slide. I'd like to just highlight a few of our key assets. We've talked quite a bit about our evidence-based practice center and their work in developing systematic reviews in telehealth that are widely used. I just want to point that these are extremely relevant to setting research agendas, to creating practice guidelines, and to also coverage determinations. This group has been extremely restless. And as you can see in the lower left-hand portion of the slide, although they were previously generating at least one strong review every year, currently this group has 5 projects in the pipeline that will be released within the next year or two. Integrated pain management programs. And I'd like to note that this is in a partnership with CMS. These are oftentimes done through interagency agreements. Evaluation of mental health apps with SAMHSA. Rural health provider communications with HRSA and NIH. I'll be speaking about that a little bit more in a moment. Antenatal care with the American College of Obstetrics and Gynecology. And lastly, telehealth for women with HRSA. So lots coming in the near future. Next slide. I wanted to highlight this particular project with the EPC division is doing because it is truly a collaborative among the leading research partners in the federal government. This is a project called Improving Rural Health through Telehealth Guided Provider-to-Provider Communications. It's part of the Pathways to Prevention workshop sponsored by NIH. But this is truly a consortium of HRSA through their Federal Office of Rural Health Policy, or FORP, through our own EPC division, through the NHLBI of NIH, through the CDC and the National Center for Advancing Translational Sciences. And this is the best all gathering under one topic. And the presentation and meeting are being held just in a few months. Next slide. We're extremely proud of the work done by the Division of Digital Healthcare Research. I'd like to add, and the second bullet point there is this group has been extremely active during the pandemic with a flurry of research grants. They're looking at the essential questions about delivery of healthcare during the PHE. Some of these relate to telehealth. And this is a sampling of 5 projects that DHR has either completed or is in the process of completing in a diverse group of areas in telehealth. Telerheumatology with the Alaska Native Tribal Health Consortium, speech telerehabilitation after stroke, telepsychiatry in nursing homes, patient choice in telemedicine with Kaiser, and the role of telehealth in the COVID-19 pandemic with USC. The importance of doing research in telehealth is characterized by the paper from Health Affairs that I put on the right-hand side of the screen. This is a very small but interesting study of the unintended consequences of telehealth solutions. This is a study from University of Michigan's telehealth incubator. And what they looked at is they used claims data to look at 2 cohorts of people, patients that were receiving upper respiratory tract infections, A, through their primary care physician, and B, using a third-party telehealth provider. They looked at the outcomes and surrogate markers such as emergency department visits during care of those 2 cohorts. And they found out that actually the outcomes were almost the same. The difference was in the group that chose telehealth doctors, third-party telehealth doctors, there was a much higher rate of people checking in with their own primary care physician practice after that visit. Is it because it deteriorated? Is it because they wanted just reassurance that they were on the right track or on the mend? That part the investigators were unable to say. But suffice it to say that the utilization was actually paradoxically increased in the telehealth cohort. So as a cost savings mechanism, we may have more to learn. Next slide. We have already talked about the ECHO Nursing Home COVID-19 Action Network. The playbook for Project ECHO had been cast in 2011 in New Mexico. Fast forward 10 years, we have a new virus, COVID-19, a new burning platform. The fact that nursing homes were under-resourced and bearing the burden of the pandemic. And I think through the amazing work of people at AHRQ, an entire curriculum was created for 9,000 of the country's 15,000 nursing homes in a consortium between AHRQ, IHI, and Project ECHO at the University of New Mexico School of Medicine. This project was stood up in a matter of months, and it launched in 2020. The 16-week curriculum was made available to these nursing homes, impacting 1.7 million nursing home residents. This again reiterated the powerful impact of telehealth as a public health tool. Next slide. I'm just going to make a few comments about CAHPS and MEPS. Dr. Brady did talk quite a bit about CAHPS and how they pivoted last year from in their clinician and group practice survey, from looking specifically at a 6-month view of ambulatory care to looking at the telehealth, or looking at the patient visit. There, the 24 data elements in CAHPS 4 could be configured for either a virtual visit or a live visit. When data comes in through the CAHPS survey, we're actually going to have remarkably important information about looking at the quality, safety, value, and patient experience in telehealth. This is a massive gap, and the informatics firmament right now is having access to this information. We could even be looking at telehealth versus live care in the same patient. So we're very anxious for this to move out of beta testing to be used as a true quality improvement tool. And I can tell you, in presentations we've been doing over the past couple of months, there is interest in using CAHPS. We have had other agencies reaching out to us asking how they could become involved moving this tool into the field. Next slide. Lastly, MEPS, which also collects a constellation of data elements. Last year added telehealth as one of the data elements. This creates an enormous opportunity to begin mixing and matching information to create new ways to view the deployment of telehealth in the population. For example, we can begin matching telehealth and non-telehealth encounters with things like gender, race, ethnicity, zip code, broadband access, cost of care, out-of-pocket spend, health insurance coverage, et cetera, et cetera. I think that as this resource comes online, we will really know so much more about the key issues of equity and disparities in healthcare, as well as the economics. Next slide. In summary, the rapid expansion of telehealth during COVID-19 pandemic has created historic opportunities. Unfortunately, with little evidence to guide implementation of policymaking, we're addressing those things. While telehealth technologies and systems have the potential to increase access and convenience, they also have the potential to create new patient safety issues and increase utilization without improved outcomes. We're seeing that in our research already. And it is critical to evaluate the effect of telehealth implementation efforts on healthcare quality, safety, equity, access, utilization, and value. Next slide. But we could use your guidance. We have many questions, and we would like your advice about how we can move forward to engage in this space. How might we engage the private sector? Which stakeholders would we be engaging? How can we better support primary care practices implementing telehealth? What new data and analytics tools might we need? And given AHRQ's capacities, how can we have the most impact in advancing the goals of access, equity, and quality in telehealth? Thank you.
Great. So let's go back to the last slide if possible. So I want to hold on that for a sec there and open this up to NAC if you guys are if Keith and Jim, you guys are okay with that. But I do want to jump on one. Well, I guess one thought addressing kind of the fifth bullet point, the last bullet point here. I struggle a bit. So I'm the digital guy, right? So telehealth is, that's right up my alley. So I think about it a lot. I struggle with utilization as a metric. When you think about telehealth as a channel for care. So again, we've talked about this before, where telehealth isn't necessarily its own thing. It's a way to get a certain level of care. And so, I wonder if utilization really is a metric we should be tracking versus really understanding the ultimate outcome we're trying to achieve. Right. So if like what's bolded in the 5th bullet point, access and equity and quality. Yes, yes, yes. Utilization, I don't know. And so I wonder how you all are thinking about that, or from a vis-a-vis telehealth.
If I might take the first swing at this, Jamie, Dr. Robinson, you're raising a wonderful point. We don't know whether utilization is a good or bad thing. Let me give you an example. We've been working with a psychiatry group, and they told us that during the pandemic, when they switched almost entirely to a telehealth platform, their utilization, the number of visits, went up by 26%.
Mm-hmm.
Their no-show rate dropped to 0.
Mm-hmm.
Now, is that a good thing? It's kind of hard to say it's not. I mean, people are connected to their patients in a much better way, but obviously this has economic impact. So this is where having access to good high-level information and knowing what to look for is really important in this area.
Yeah, no, it absolutely. It of course it has an economic impact because we're paying to do stuff instead of paying for outcomes, which is why we still have that same challenge. I'm going to look here and see. I see. Asaf, can you? No, Greg. Greg, can you? No, Asaf first, then Greg jump in on comments. I see you guys pull comments into the chat. So Asaf first.
Yeah, I'm piggybacking on your comment, Dr. Robinson, really about the fact that I will say we have significant policy level worries, especially in many of the outpatient disciplines, around not just utilization, but but putting telehealth into a fee-for-service mindset. The evidence is overwhelming that fee-for-service for most outpatient disciplines, inclusive of primary care, but not limited to, so psychiatry, others, is a corrosive payment mechanism that distorts the accomplishment of end outcomes and values and access and core team-based functions. So when we see, for very understandable reasons, and I'm a practicing primary care physician, telehealth was a key lifeline. And I said in my earlier comments, not a question of if it's going to continue, but how do we best make it continue to meet our goals? I understood the looking at telehealth from utilization perspective, paying for it in a fee-for-service mechanism as a lifeline. But now that we're in a different phase, and I think it's very important for us to not just encourage what could be the unintended consequences of just encouraging lots of phone visits or telehealth visits to augment a fee-for-service line of business when that may not actually be what our populations need. And so thinking in a more nuanced way about bundling mechanisms or other payment models that don't just encourage, the widget-based visit models, I think is critical.
Yeah, no, 100%. Agree. And so, Greg, you have a comment here that it's really interesting because I think we've talked a little bit about this idea of a digital divide, and I think that's might be what you're getting at. You want to elaborate for the group here?
Yeah. So for since 2013, I have been fortunate to work with AHRQ and have funding to measure digital maturity in long-term care and to look at how IT systems are being implemented and used and integrated. And one of the factors that I think that we lack really good measures in is structural capabilities. And structural capabilities are super important in non-acute care settings because of meaningful use. acute care settings have pretty much consistently similar types of systems and ambulatory care settings. But if you look at other healthcare sectors, those structural capacities are much different. There are differences in connectivity. There are differences in support services to manage different kinds of healthcare activities like lab and radiology and pharmacy, which are all important in telehealth, but they have different mechanisms for accessing those resources and for using those resources and for integrating them into the delivery of care. And every system is different because they're unique systems unless they're corporate owned. And even in corporate owned facilities, you'll find some variations among the different systems within that corporation, depending on who the users are in the field. And I don't really believe that we have really good measures of structural capacities. And unless you understand the capabilities of a facility, and understand the differences and the disparities that exist because of those differences in structural capabilities, use is a very, it's hard to understand use until you understand what they're capable of doing. And in the long-term care sector, I think that's a huge area of sort of a gap in our understanding. And this push to use telehealth, because of the rural settings and the different variations that occur in those settings, I think we have maybe created even a wider gap in the disparities between what urban and rural settings. For example, urban settings tend to be much more highly integrated in long-term care and use systems that are integrated into their systems versus rural settings, which use very disparate systems and they're not well integrated. And telehealth fits into that schema as well. So I think there are issues for patient safety as well as quality measurement in that space.
Yeah, that makes
So
sense.
Edmondo, this is Jamie. So I just wanted to remind folks that, we do have this subcommittee that is looking at quality measurement and that will be reporting out in November. But obviously, one of the things that they are thinking about and will be making recommendations to the NAC on will be about gaps in quality measurement. And I can already tell you that telehealth and that area has come up for discussion and will be explored further.
Yep, makes sense. And along those lines, I know Chris had a comment if she wanted to further that around the metrics and measurements around this. And then Melinda, I did see your hand up as well.
The only thing, and I made a comment in the chat box, the only thing I was going to say, as an organization that went to literally, I'm going to say millions of telehealth visits during the pandemic and had started with next to none, the struggle with how do you evaluate the relative values, and not only the measure, but what provider expectations, et cetera, are huge. And I just chopped in there. I think, and many in our organization believe that this is a key place for AHRQ to become active and to help develop, again, knowing that there will be cursory initial measures for quality, safety, and equity in telehealth, which is what we've been talking about. Can't have one without the other. And AHRQ is in the best position to take that broader perspective in looking at and establishing some baseline for the industry so that we don't end up like we have with so many patient safety or even the diagnostic improvement stuff, where people begin to develop their own measures and then they're reluctant to give them up, right? So
I think that's a really important point. I think we at AHRQ are always thinking about and not struggling, but really trying to make sure, given the environment that exists here, what should be AHRQ's role specifically? Like, where are we not, where can we really have the most impact in the work that we're doing? Obviously, given that we're small, but we have these unique expertise areas. And where should we focus? So that point is well taken.
Melinda.
So I've been thinking a lot about your questions on how to engage the private sector and how to make AHRQ's research more relevant and more widely used by health systems and private healthcare providers. And it occurred to me that that something, I think it was Chris said earlier, that there just aren't enough of us to disseminate this information. We have to reach new audiences in new ways. And what you presented regarding the MEPS was really thought-provoking. And I wondered if there might be a way similar to the way there's the MEPS IC, where you follow up with insurance companies and you find out about the benefits and things like that that individuals have. Could there be a version of that MEPS telehealth follow-up, where you find out when there's been a telehealth visit, what were the modes, what providers were involved, was it a health system, was it a private provider? And then you're able to use that as a sampling frame to follow up and really engage with a broader group of companies and private sector individuals and health systems than you might have if you just waited for them to come to you and either join a partnership or be part of a proposal. And if that would help you to gather more information more widely about this field. So that's my suggestion.
Yeah, that makes a lot of sense, and I know the AHRQ staff is taking and ingesting all of these suggestions or recommendations, and I'm going to assume, David, that includes the chat that's coming through during this meeting.
We share the chat, by the way, Armando, with our folks here too as well.
Okay, just I just want to make sure that we're capturing all of this really rich feedback that's coming from the group. So awesome. And I know Gretchen had a quick comment, but I'd love if you can to expand a little bit. You mentioned your EQF in terms of thinking about or helping around metrics. Can you expand just a bit?
Well, I guess I was thinking that National Quality Forum has done some work. I just did a quick check. They had an approach to telehealth quality published in September of 2017. So it predates the whole pandemic impact. But I think it's just worthy to touch base with kind of the recognized group, which was really a coalition of people doing work on quality metrics in this area as well.
Yeah, and I'll say that is something in the subcommittee that we are talking about, obviously taking into context these other groups that exist and the work that they've already done. We don't want to be in the position of, again, duplicating. We want to be in the position of supporting, creating impact, and making sure that we're using, our capacities to do that.
Yeah, right.
I can't tell you that the call for data is extremely strong right now. People are looking for data to guide policymaking, and the CDC is also doing a fair amount of work. And they've been engaging some of the third-party vendors to see if they can't learn a little bit about how telehealth is being used in the field right now. But that obviously is so limited, because I think you're only talking about users. When you look at the Medicare database, you're only talking about people covered by this health plan. There are massive population segments that we're not reaching. And I think that's where there's so much excitement around MEPS and the CAPS tool, is that we may have ways to reach new populations that really are affected by telehealth in an adverse way and be able to inform future work.
Yeah, along those lines, and I'm sure you guys thought this, but the American Telehealth Association would be a really great partner around some of the things you're mentioning, Keith, as well.
Right.
Keith or Jamie, I have one quick. I see you, Susan. One quick question, I guess, is as your bullet point number 3, as you mentioned, primary care practice implementation of telehealth. How are you thinking? Were you thinking that there's a playbook of some sort around launching or optimizing your telehealth practice? How are you thinking about that in terms of how we could help or give recommendations or advice?
If I may, Dr. Robinson, we're beginning this process right now, and the fortunate thing is we almost have a framework for begin looking into what the needs of primary care practices are. We had a primary care learning community call with nearly 100 people on it just a few weeks ago, and the topic was telehealth. And some of the things that we heard is that a lot of these practices, especially smaller practices, were faced with lots of questions from vendors. high connection fees, what product to use. It almost harkens back to the old EHR selection days of a decade or two ago. And these practices are intimidated. They want to be in this space. They're not sure with whom they should, who are the trusted partners. So I think as we look about the EHR deployment days, there are lessons learned that we can begin fielding now. I think this is we're just beginning these thoughts right now of how we can begin engaging evidence now players, our PCLC, and perhaps the PBRN network, and trying to begin answering these questions by first helping with needs. I can tell you that a lot of the primary care practices are struggling with the economics. How many computers do we need? How many phones do we need? Should we have designated telephone nurses now? We never had that in this volume before. So lots of questions, and perhaps we can be engaged.
Yep, makes a ton of sense. Patrick, I've seen your hand up, and then Susan after Patrick.
Oh, right. Hi. Good morning. Yeah, I just had a few thoughts, I guess, to amplify on what others have suggested, based on my experience as an academic primary care physician. But I think with this explosion of telehealth visits, we've encountered some significant challenges, also some significant opportunities, some things that cause us to rethink perhaps what we've accepted as the way things are done. So for example, what is the role of the physical examination specifically? When is it necessary to do a physical examination? When isn't it? So we're challenged, obviously, in the telehealth environment to really identify, do we pull the patient in for an in-person visit because we need to do that physical exam? Can we have them sort of expose the relevant area of their anatomy and get the information that we need by visual inspection, for example? So some very interesting questions about what's the role of the physical exam. Similarly, I think that we've been challenged by, and this relates to the equity issue, how do we involve an interpreter in telehealth visits? It's challenging enough to involve an interpreter when they're in the room with you, but when we're in this often mixed audio video environment, and you may lose the ability to signal, with body language and so forth, and to understand some of those cues that you get both from the interpreter and from the patient. So very important equity related questions to understand a little bit better about how to facilitate interactions involving interpreters via telehealth. And then we talked about the digital divide. I've been surprised and disappointed at how often we plan video visits that actually turn out just being audio visits because of bandwidth issues, because there's too much stuff going on in the background on one end or the other, or just because it turns out the technology doesn't work. So again, we plan video, we end up with audio. What do we lose? How do we make up for those gaps? So lots of interesting sort of practical issues in how we actually deliver ambulatory services into the home via telehealth that AHRQ can explore.
Yeah, great points, Patrick. And I love, again, digital divide's a little bit of a point for me that I like to follow through on. This idea of the interpreters from an equity perspective is fascinating. And I wonder if, as we talked about this idea of primary care practice implementation, I wonder if there could be some best practices around incorporation of interpreters, interpreter services as part of your overall package. Really interesting work there. Susan, I think you were up.
I just want to, I have to say that what Patrick just said, I just got a request this morning to help our primary care practices think about how we can educate our patients about why they don't necessarily need a physical exam when they're doing a virtual annual visit, and that there's probably more value in taking that time just to talking and communicating about other things. But that's one of the areas where we see the most comments and concerns in our patient comments about virtual health. But again, I think I've shared this before, in our system, we get higher scores in our patient experience data on telehealth visits than we do on face-to-face, which I think is fascinating.
Yep.
But the other point that I wanted to make is that two other points. One, I think that what Chris said about the importance of AHRQ promoting and helping to publicize, promote, and create partnerships with other agencies to use all of the measures that are already developed so that we don't have all kinds of poorly designed measures sort of popping up everywhere. I think that's an incredibly important role. And I'm sure that's something that our subcommittee is going to be talking about. And there was one other point I wanted to make and now I forgot it. So I'll be quiet. Oh, I know the other point I wanted to make. I think that trying to figure out a way to have conversations with the private sector telehealth organizations is really important. In Massachusetts, when we talk to our payers about continuing to pay for telehealth visits, one of the issues they often raise is that they're worried that with organizations that use companies like Teladoc, just as an example, and I don't think this is a Teladoc problem, I think it's a communication or other kind of problem. What they often see is there will be duplicate visits because if somebody uses Teladoc for an urgent visit, they often want to confirm that whatever advice they got or whatever with their PCP. So they actually do end up having two visits for the same problem. And how do we work on that? I think is something that I think you can only do by coordinating and having conversations with the private sector vendors.
Makes sense. It looks like I see Youngling. Youngling, if you can make yours quick, I'm gonna let you be the last comment.
Okay, thank you. Quick comments. I don't know, have mentioned stakeholders, what should be engaged. I think the state medical board might be a stakeholders to engage because they set a standard care issue. Every state medical board, at least Washington, they try to develop telehealth guideline. And I think help them educated or communicated will be help with the state at a state level. Another thing, stakeholder, you probably all mentioned patient and families. I think maybe do a survey, especially in those rural population, and what is their difficulties, obstacles, that to engage in telehealth. On the new data and analytic tools, and I was just wondering, in your slides you mentioned shared decision making. I just wondering what will be difference in person use patient ads versus use in telehealth. And I would like to see maybe some research and some analyze to be done to look at shared decision making tools, patient app in the telehealth environment to better help facilitate the decision making from both sides. Thank you.
Yeah, outstanding. Thanks, Youngling. Any kind of comment, final comments from Jamie or Keith on this topic?
You all have given us so many ideas here. I think our next meeting is going to be pretty busy. Every one of these suggestions was terrific, and I definitely like you've also helped us prioritize a little bit. We've had equity and disparities front and center to our work from the very beginning, but now I think you just reiterated how important this is. Looking at people with disabilities, et cetera, we need to really double our efforts to make sure we're engaging all populations in this work.
Awesome.
Yeah, and I'll just add that obviously this is not a discussion that is a one and only. As we imagine we'll be talking about this, that we know for sure at our next NAC meeting, at least in the broader context of measurement and what AHRQ's role should be. But we'll be coming back to this, and we just appreciate all your guidance as we continue. Thanks.
Awesome. All right, let's take our for the East Coast folks, our lunch break. For the West Coast folks, maybe grab a bagel or something. Let's come back sharp at 12:35 Eastern, 9:35 on the West Coast. And I mean sharp. All right, awesome. All right, it's 12:35. Let's get back into the agenda. So the next topic on the list, really talk about patient safety. So we've really set this topic up pretty much throughout the day in terms of patient safety opportunities. So with that, I really want to go ahead and turn it over to Jeff and Aaron. Dr. Jeff Brady is the Director for the Center for Quality Improvement and Patient Safety. Aaron's Deputy Director. Jeff, go ahead and take it away.
Great, thank you, Dr. Robinson. Really appreciate that. As you said, yeah, we were really pleased to hear a lot of the discussion this morning. We were listening intently, even though the stated topic wasn't patient safety. We definitely are paying attention. So I'm happy to be joined by my colleague, Aaron Grace. Aaron serves as the Deputy Director of our center. So we're gonna dive right in. Here's next slide, please. Thank you, Jennifer. This is the agenda for our session. We're gonna move really quickly through this, give you a brief overview of AHRQ's patient safety programs, followed by a reminder about the National Action Plan to advance patient safety. Next, I'll describe AHRQ's focus on improving diagnosis and our efforts to expand our work in this area. And of course, finally, and most importantly, we want to hear your feedback and recommendations. So next slide, please. So in particular, we want to focus your attention and advice on our patient safety challenges that you are seeing, your organizations are seeing in the field. Next, again, the focus on the National Action Plan, we really want to get your feedback about how we can leverage the plan in our work. And then finally, again, focused on diagnosis, improving diagnosis in healthcare. We've been at this for some time now, and there has been interest, but it's definitely not meeting the level of harm that's created by this problem. So we want to get your feedback about how we might expand both interest in the field and our actual work and funding around this topic. So with that, I'm going to turn things over to Aaron. Thanks, Aaron.
Thanks, Jeff. If you could go to the next slide, please. And I will dive right in. So the next slide is AHRQ to show you, if you could go to the next slide. Thank you. AHRQ has 3 distinct but interconnected divisions that make up our main patient safety program. And as a quick overview to our 3 patient safety divisions, they are listed in chronological order of when each division was formed. The General Patient Safety Division, formed shortly after the IOM to Err is Human, was the initial patient safety program. Following the Patient Safety and Quality Improvement Act of 2005, the Patient Safety Organization program was formed. And subsequently, AHRQ received increased funding to expand its emphasis on healthcare-associated infections, or HAIs, which includes combating antimicrobial resistant bacteria, or CARB. And on this slide, you see the names and faces of the team members who lead each of these divisions. Next slide, please. Our patient safety programs and the way they operate fit nicely into the learning health systems model that AHRQ has championed over the years. Our programs also align with AHRQ's core competencies of health systems research, practice improvement, and data and analytics. Our patient safety research generates evidence across the research continuum, but beginning with the basic research to understand the harms associated with healthcare, to implementation research that translates the evidence into practice to prevent the harm. Experience throughout the patient safety field has shown us time and again that successful practice improvement depends not only on the technical aspects of care, but also on other foundational factors such as just culture, the effectiveness of teams, patients and family engagement, and the safety of the healthcare workforce. And we strive to represent this reality throughout our programs and address both types of factors. Finally, information from data measurement and analytics is obviously a key ingredient to developing knowledge to perpetuate the improvement cycle. Next slide, please. Here you see the specific priorities and targets that are the focus of our projects, where we apply the framework of AHRQ's core competencies and the learning health systems model. We first need to understand the causes of patient harm, not only in the hospital, but in all settings of care and during transitions between settings of care. Also, we strive to ensure that improving patient safety is not an add-on or an additional burden, but that it fits into the existing clinical workflow. And AHRQ develops strategies to prevent many different adverse events that occur in multiple settings, such as hospital-acquired conditions, diagnostic errors, healthcare-associated infections, medication safety events, and more. Please, next slide. Making Healthcare Safer is an example of AHRQ's patient safety research that has been translated into a format for practical use. The first Making Healthcare Safer document outlining key evidence-based patient safety practices was published in 2001. It provided crucial information to inform patient safety improvement activities. And we've heard from the field that this synthesis of information is very helpful to focus patient safety improvement efforts. Making Healthcare Safer 2 provided new information in 2013 to a more knowledgeable and experienced audience. Making Healthcare Safer 3, which we just published last year in 2020, is a critical analysis of existing and emerging patient safety practices and includes a table showing how assessment of patient safety practices interact and intersect across the 3 reports. Next slide, please. We also translate evidence into tools for improvement, and this slide is intended to show that the agency has published many tools to translate research into practice. Next slide. Ultimately, we are focused on the impact of our efforts, including the ability to measure and demonstrate impact. One example of measuring impact is AHRQ's measurement of the national rate of hospital-acquired conditions, and I think that's even been referenced earlier in the meeting today. National efforts to improve patient safety, led by AHRQ, CMS, and the Department of Health and Human Services, have resulted in significant improvement over time. Next slide, please. AHRQ has been focused on equity as a domain of quality for many years. AHRQ's National Healthcare Quality and Disparities Report provides some important insights, including how some patient harms place higher burdens on different groups of patients. Here you see a summary of patient safety measures from the report and the mixed picture in terms of population comparisons. For example, when comparing the experiences of Black patients to those of white patients, 10 measures showed worse quality, 16 measures were about the same, and 7 safety measures were actually better. Our intent with this information is to focus attention and target action where it is most needed. In this case, to address disparities in patient safety. Next slide, please. And we have included a link to AHRQ's Patient Safety Network, or PSNet, prior to today's meeting. PSNet serves as a one-stop shop for patient safety information and includes patient safety information across the entire field, not just AHRQ resources. In addition to the information such as publications, tools, resources, etc., AHRQ synthesizes evidence-based information to provide resources such as patient safety primers, perspectives, and web M&M cases with continuing education opportunities. Next slide, please. Now I will turn it back to Jeff, and I look forward to the robust discussion from the NAC to provide input on AHRQ's efforts to improve patient safety. Jeff?
Okay, well, thank you, Erin. If we could get the next slide. So now let's turn to the National Action Plan to Advance Patient Safety. I can tell you this was an incredible privilege to co-chair the steering committee that created this report. That was with my colleague, Dr. Tejal Gandhi, who was at the Institute for Healthcare Improvement at the time. And IHI brought together representatives with a shared interest in engaging patient safety efforts. And our intent is to provide a clearer, more unified vision in terms of what's necessary to do that. Recall that in the discussion, we want you to think about how to leverage, how we can leverage the National Action Plan to sort of support our mission. So we're going to be coming back to that. We hope to get your thoughts on that. Next slide, please. So there was general agreement among the committee, the National Steering Committee for Patient Safety, that while progress has been made, it hasn't been enough. And unfortunately, harm still occurs all too often. We recognize that there's a substantial amount of work that is happening, but it's varied and disconnected. And that really still is the case. We've heard about that some today, I think just within the federal government even, although lots of energy and interest in sort of being more collaborative and you know, as David mentioned. Unfortunately, though, our current status across the board throughout the field is there still is duplication of effort, diffusion of accountability that was mentioned today, barriers to collective learning, and all of that we think was resulted from lack of a national strategy. So obviously better coordination is needed, and that is a major fundamental focus of the plan. It's interesting to note, just to put this in a time context, that most of the plan was actually completed as the pandemic emerged. We didn't release it at that time because we wanted, this is not the kind of plan that's used in an emergency, right? This is sort of foundational work that we felt it was a hard decision, but we needed more time and attention from the field. But what we did see was that the experience throughout the pandemic really underscored and validated just about every recommendation in the plan itself. Next slide, please. So the higher degree of coordination and collaboration that we want to achieve that I've already mentioned, that's represented in the charter and in the vision for the National Steering Committee. And since the plan has been released, AHRQ continues to work as a key partner on advancing the plan with the National Steering Committee's current focus on wider dissemination and implementation. Next slide, please. At a very high level, the plan is organized according to 4 foundational areas that are all interdependent. You likely recognize the importance of all of these areas to patient safety. Some have been mentioned today already, maybe all have been mentioned already. I think my colleague, Dr. Gandhi, put it very succinctly when she says these are all prerequisites for patient safety, sort of end of statement, right? You really have to have these in place in an organization, in the system writ large, in fact, to have a safe healthcare system. So we sent a link to the plan. I hope you've had an opportunity to review it. There are 17 recommendations. And again, they're organized according to all of these 4 areas. Next slide, please. In the early stages, when we began planning this work and developing the National Action Plan, the steering committee agreed on some core principles. You see all of our core principles listed here. I want to call out one that I'm particularly proud of on behalf of the committee, and that's advancing equity. It was one of the core principles. You see it highlighted here in red. As with the other core principles, this concept is not just represented at a high level. It carries through down to the implementation level in the plan with specific tactics that help organizations actually achieve this. So this is not just a commitment to an ideal, but it's actually sort of a blueprint for what's necessary to achieve it. Next slide, please. In addition to the plan itself, where we provide the recommendations, again, the 17 recommendations, working with the team at IHI, the full steering committee and the subcommittees developed a self-assessment tool for organizations to take stock in their own status with respect to the necessary capabilities and organizational competencies. And the idea is, armed with that knowledge about their own specific tailored status, organizations can draw from this third document, the implementation resource guide. So this full set of information together, the Safer Together plan itself, organizational self-assessment tool, and a set of robust implementation resources, that really helps the action plan live up to its title of a true action plan. There are things that organizations can and the committee thinks must be done for safe care, and those are represented here. Next slide, please. So shifting more specifically to our role at AHRQ as the Federal Patient Safety Research Agency, we've already relied on the plan and used it to help inform 2 virtual meetings that we hosted late last year. And during those meetings, we considered with a really helpful group of stakeholders the most important questions that patient safety research could and should answer. We asked participants to take into account major shifts in care delivery that resulted from the pandemic, including the expansion of telehealth we've already talked about today. And in the discussion, we sought to maintain a total systems perspective across all settings of care, so that kind of continuity with attention, though, to specific issues in specific settings of care. Next slide, please. So we shared this link also. I hope you had a chance to look through the questions. This is our summary, again, available online. And we just simply titled this Patient Safety Research Opportunities. And those opportunities are represented by more than 88 questions that patient safety research could answer. We organized those questions into 10 themes, and that's what you see on this slide, the first 5 themes. So some of the examples of things that emerged from those discussions were things like the effects of social determinants of health and systemic racism, specifically on patient safety. Obviously, there are broader questions there beyond in other quality domains, but obviously as well, safety is an important one of those. Similarly, understanding and reducing harm caused by diagnostic errors. You'll hear more about that. Next slide. Some of the other themes were things like enhancing measurement and the effective use of data for improving patient safety. Again, detailed questions under each of these. And then finally, we've heard today about structural things in nursing homes and long-term care in particular, but more generally even, what does the healthcare infrastructure look like for patient safety? So I hope you've had a chance to look at those questions, and we'd love to hear your feedback on those questions in particular. Next slide. Okay, let me wrap up here by talking about this still emerging area of improving diagnosis. Next slide. The National Academy published their report on improving diagnosis in September of 2015. As with other National Academy of Medicine reports, this one highlighted important problems, and it had ambitious ideas about addressing them. It's hard to believe it's been almost 6 years since the report was released. And while some things are happening, I think some important things, we are definitely not on a pace for national progress that meets the ambitions of the National Academy of Medicine Committee for Improving Diagnosis. And we've got some representation among you all that know about this committee, of course. And so awareness is increasing thanks to groups such as the Society to Improve Diagnosis in Medicine and the Coalition to Improve Diagnosis. Some work's being done by the Gordon and Betty Moore Foundation. And we are also supporting some important research, but it is definitely not on a scale that will get us where we need and want to be. Next slide. At AHRQ, we have managed to target some limited resources in ways that should catalyze larger scale interest and actions. Here you see a list of some papers that we commissioned on topics that set the stage for improving diagnosis. Current issues include things like telediagnosis. Again, lots of interconnections between our different programs and work groups within AHRQ. Other issues include the use of health information technology for engaging patients in diagnostic decision-making, specifically in the emergency department, where a lot of diagnostic activity takes place. We're also developing and pilot testing 3 different improvement resources for diagnostic safety and quality. So that's hopefully jump-starting some of the activity in the field, and that's a role that AHRQ has played across many different patient safety issues in the past, and hopefully we'll be able to follow through with more work. Next slide. This is one example of a resource that I mentioned on the prior slide, and it's work that's focused on operational measurement of diagnostic safety in order to try to get some interest in the field among operational healthcare delivery systems to try to provide some practical guidance as they start to work in this area of diagnostic safety. Next slide. So there's a lot here, but this is from that report. And it's a graphic form, again, from that issue brief, intended to help organizations understand which data sources are most useful right now. Different data types and the methodologies have different degrees of availability and accessibility in operational care. Some of these are still exploratory, while others are more mature. And so you see those issues represented on the Y and X axes. The data sources that are in the upper right are generally more available and mature for use in improving diagnosis. Again, right now, there's work that could happen right now in forward-leaning systems to improve diagnosis. So things like incident reports, malpractice claims, high-risk chart review, those have demonstrated some of the earliest promise. Although ultimately, we really think a holistic view that takes into account this full diverse set of approaches that draw from multiple data sources, that's going to drive the most improvement. So that's the kind of innovation that we hope to support in a more robust program. Next slide, please. So let me turn to our HAI program, which is a long-standing program. I've actually come to appreciate it as a great model for our expansion of improving diagnosis, our work on improving diagnosis. For several years now, AHRQ has supported a successful safety program focused on HAI prevention and combating antimicrobial resistant bacteria, or CARB. Fundamentally, the HAI program focuses on both research and improvement. And this combination in which we work to advance the research to practice improvement pathway has achieved some really impressive results. We translate the findings into tools. I've given an example of one of those earlier in the day today, just one example. And so again, I think this is a great model for diagnostic improvement. Next slide, please. An important part of that approach that we've applied in the HAI program has been to adapt the proven CUSP methods to various HAIs. Again, I think some of our NAC members have very in-depth experience with this. It shouldn't be a surprise that this works because CUSP combines foundational factors such as culture, patient safety culture, teamwork and communication with checklists of evidence-based practices to prevent HAI. So it's fairly complicated to do the adaptation, but we've done that with some success. You see the results which speak for themselves. Different types of HAIs in different settings, again, thoughtfully adapted with great results. We've also adapted the CUSP challenges to antibiotic stewardship in multiple settings. Next slide, please. So this is, I think, my final slide, and it's a summary of the funding history that made some of that work possible that I mentioned in HAI prevention and CARB. Thankfully, that funding has been stable in the $34 to $37 million range. And like diagnostic errors, that amount of funding is still modest in comparison to the enormous human costs and financial burden that both HAIs and diagnostic errors place on us all. So I think this scale of funding not only comes closer to matching the size of the problems, it allows us to test solutions on a scales that will allow us to support driving progress. I think the next slide might be the questions. We can move on to the next slide. And so with that, Dr. Robinson, I'll turn things back over to you. Thank you for your attention, everybody.
Absolutely, thank you, Jeff. And Aaron for your presentation. There's a lot here. And actually I saw some comments already popping up on the chat. I'm going to pull you guys forward, the ones that I saw. One thing I had a question on, though, if either Jeff or Aaron to answer is, as you were describing one of the components that you were looking at from a patient safety perspective, I was wondering about, it occurred to me, how you think about the intersection between provider well-being and patient safety. I didn't see that as a specific question called out. I'm just wondering how you guys are thinking about that.
Great question. So if you go back to the foundational areas in the National Action Plan, the safety of the healthcare workforce is not a brand new concept, but a new concept in terms of its association with patient safety. All we have to do is look back over the past year and a half to see the extreme demonstration of that close relationship. The way I like to summarize it is, it's hard to ask somebody, in this case a provider, to think about a major professional responsibility they have, which is to ensure the safety of patients, if they themselves don't feel safe. And that safety for the healthcare workforce really should be considered in two dimensions. It's their physical safety, obviously falls, back injuries, and also their psychological safety. And that has very close connections to safety culture and, being willing to speak up and ultimately supporting that learning process for improvement. I hope that addresses your question.
Yeah, I think so. There's one nuance there, and I think it's baked in there, but I wonder about burnout, right? So I wonder about, because part of it is, I think I remember what triggered my question, which was the electronic medical record, health IT, and all of that, and I worry about how much burnout's coming through a lot of the providers, just having to deal with these systems that we kind of are forcing on them in a lot of ways. And then I think, well, if they're spending literally 2 to 3 hours a day after they've seen their patients, dealing with, kind of diagnosing the computer, how much just capacity do they have to really be effective champions around patient safety? I think that was the nuance I was wondering about it.
Yeah, great point. I think Erin alluded to this when she talked about our really consistent attention to integration with workflow. You know, we could design a perfect solution, perfect in air quotes, that keeps patients absolutely safe. But if it's not feasible to implement because providers just don't have capacity, it's useless, right? I mean, so I think that is critically important. All of that contributes to burnout. So I think there's similarly, this issue tracks over into other emerging patient safety issues like diagnostic safety, where sort of cognitive load and sort of considering whether the information systems are truly supporting good care, good decision making, or they're really just, as you point out, contributing to burnout with more cognitive load, seemingly solving the problem with, you know, with alerts or other kinds of interventions, but actually contributing to it. Those are all represented, I think, in our program.
Got it. Makes sense. Susan, I saw you wanted to bring in some patient experience. Susan, you want to elaborate a little bit?
Oh, thank you. I just wanted to mention that I think that we also need to think about what we can learn about diagnostic error from systematic reviews of comments that come in on patient experience surveys, especially ones that have been processed with natural language processing. Because in my system, we get a lot of feedback from these comments, and the ones that are flagged as what we call a service alert are often talking about diagnostic error. Failure to close the loop on referrals, not getting important test results back, or frankly, just diagnostic error with the physician ignoring what the patient was saying, and they subsequently go somewhere else and find out they've got something serious. So I think that's a source. And I think just in the patient experience world, since the very first national survey I was involved in, actually in 1989, of hospital care, where we got comments, we didn't frame them as diagnostic error comments. They were sort of like oops comments, but they were often flagging safety events that at the time we didn't even characterize as a safety event. You know, I got taken down to get a scan that was for my neighbor, or I got, you know, the nurse gave me medications that were intended for my roommate in the hospital and things like that. So I think it's another signal that in some respects, I sort of trust more than some of the incident reporting that we get.
Interesting. No, that's good. Great point. Oh, I saw Gretchen. Gretchen, did you want to elaborate at all on your thoughts on the kind of the e-triggering chart review?
Yeah, I can. I see that it has sort of a moderate effect. E-triggers enhanced chart review has a moderate effect on, I guess, or moderate availability, I guess it is, and it's considered exploratory. I think it has good potential because it takes away the need for somebody to point something out if you just use e-triggers. And it has the potential probably of exposing just a lot of charting inadequacies, but it also has the better potential to expose or help you get at those rare occurrences that aren't going to come up when you do random chart review. And so I just thought I thought that chart was great, and it's a chart with all the circles on slide 85, and I would encourage just looking at all the potential in there.
Yeah, that's great. Chris had a straightforward but potentially very profound recommendation. You want to jump in on that?
I've been sticking stuff in the chat, so I don't know. So are you asking Edmondo about the tools that need to be developed and tested? Is that the one?
You mentioned both funding as well as tools.
Yeah, exactly. So I think the tools need to be developed and tested that are perceived by frontline clinicians as helping them improve diagnosis. We're all good at creating things, but if we don't have the buy-in of frontline clinicians, then we're wasting time and money and probably not going to get where we want to go. So strong bias toward developing with an iterative design process with mechanisms built into the design that ensure the usefulness by clinicians. And so this whole notion of co-production is really important. That kind of gets into an earlier comment that I threw in the comments in the chat section, that funding more safety research, specifically partnership research, where researchers work closely with clinical operations and health system leaders. And the challenge is always, who's going to fund this? This whole notion of embedded researchers, everyone loves, but operations people aren't going to fund it, and AHRQ doesn't fund it. So, suggestion from several people that I collaborate with to figure out how we can better do that, because we will get solutions that are more feasible and probably more successful if we can bring researchers and practitioners together.
Got it. Yeah, makes sense. Greg, I saw you, and then Yali.
Hi. So I just wanted to sort of draw us back again to the telehealth sort of issue and use of different uses of technology, the changing uses of technology, right, since COVID. And in particular, I sort of want to draw attention to specific diagnoses, like, for example, people with dementia or Alzheimer's disease, or people within specific dementia units that, that may not be able to, their interactions with the technology and with the healthcare team as a result of their diagnosis it can create situations for them that they feel unsafe. Their caregivers, I think need to be involved with that. And I think there's some things about certain diagnoses with the change in the way technology is being used since COVID that we need to consider. And I think dementia and Alzheimer's disease is one of those, and we really haven't mentioned that that issue today.
Yeah, makes sense. Yangling?
Yes, thank you. I have a question and a comment and a question. The comment is about the slides, I think, is which data sources are most useful for improving diagnosis. And as you notice that the review of solicited report from patients is at exploratory stage, and there's low usability as right now. So as I think we and several other members also mentioned to incorporate patients reporting each cup or whatever. And then I think this is a great opportunity to expand these efforts. I would love to see this circle for patient reporting move onto the mature side of it and move up and into this bigger oval circle. And I think if we get funding, I think AHRQ would be in a position really can help to advance this efforts. And another thing I see this mining administrative billing data is as still somewhere between exploratory and mature, but it's a high on the on the bar. So I'm just wondering, is that because this is only because this is for diagnostic air issue, or this is for any hospital acquired infection or acquired condition or infection, would move this billing data into this oval shape of the area?
So just very briefly, the graphic that I showed is specifically focused on measuring diagnostic safety and quality. So it's, it is tuned to that specific question. Does that answer your question?
Yeah, so if for general hospital acquired condition, I assuming this administrative billing data would be moved high into the mature side of it. I'm just curious.
I think that's generally correct. I would agree with that. Yes. Yeah.
Okay. My another question is about the diagnostic area. You know, you send out, the AHRQ send out the notice for feedback on common format. And I was just wondering, the AHRQ has any plan on the taxonomy, you know, of the diagnostic area, you know, systematically analyze the, you know, the patterns or statistics and or, you know, those sort of things, not just for guide the individual providers or health system to improve it, but at the system level, the agency would look at the general pattern and causes. Is there any plan on that?
Absolutely. That is the grand plan, I guess, is the best way to say it. We would love to get to that point. I think we will get to that point. And keep in mind, of course, that the current common format that we've released for diagnostic safety events is focused just on the methodology for reporting, right? So this would be what we sometimes call spontaneous event reporting. There's a whole nother set of, I guess, what we refer to as surveillance, you know, other data methodologies that combined with reporting, I think are likely to give us a more complete picture. So I think this is, you know, again, we're sort of underscoring the reason I think we need a more robust program, because there's so many opportunities to advance all of these questions and uses of data.
Yeah, that's great. And as I said, I like to, especially for diagnostic area, patient family can identify over 80% of it. So I really like to see the circle move into, put a lot of efforts, move the circle up into the oval shape. So thank you.
Yeah, that's really good. And actually, Youngling, your comments spurred another thought from me that I, kind of, now I think I'm looking back to Susan. I think Susan had mentioned NLP earlier. So I think about patient, patient commentary or patient report, leveraging NLP. So I'm thinking about this idea of a methodological approach to leveraging NLP to pull thematic important information from patient reporting around patient safety in ways that allow it to be scaled across all providers, right? So it's not just research grade and you've got these really smart, machine learning people, but actually methodological approaches to leveraging NLP in ways that are truly scalable, so that we're really getting maybe not real time, but close to real time understanding of our patient safety environment in any given setting.
Can I make a comment about that?
Sure.
Yeah, I think, Dr. Robinson, I think that is actually something that many of the patient experience vendors already have. And they, like the vendor we use, we survey our patients within 3 days of a visit. And so we get the results the next week and we see those comments. And when they talk about something that is worrisome, we actually can reach out and contact them right away. And that has been incredibly helpful. It also is it's also an alert system. And we've had examples of people saying that they were planning to kill themselves. And we were able to get them in touch with their behavioral health clinician right away, which is something that we were never able to do before.
Yeah, no, completely agree. And I've used those types of companies. So I love it. And the question I guess the part that I hadn't seen, even though I used them anyway, is the academic output. I guess it's more of the scientific and structural, that part that I wanted to see really show, because we can share a lot of anecdotal reports about how critical these tools are, but it'd be great if we had a systematic kind of understanding of how to leverage those things.
Yeah, well, just one quick response to that, because we own our own data that we're collecting and it's going into a data warehouse. We already have researchers that are wanting to look at that for different reasons, for exactly what you just described.
Right, exactly. Yeah, makes sense. One other question that occurred to me, actually I think it was Youngling as well, spurred this question, which is, I was thinking about on the diagnostic side, Jeff, and I was thinking about I was wondering where you guys stand in terms of understanding the role of predictive analytics and predictive algorithms as they're baked into the workflow and increasingly are being leveraged. But there's pros and cons to some of those approaches, right? We've seen some of the evidence starting to emerge around challenges around equity with leveraging these algorithms. And so I wonder where does that fit in your kind of your ecosystem you're building around really approaching this patient safety issues at a national level?
Yeah, terrific question. I think that definitely that can have a place. I think right now most of the work that is close to what you're describing that I'm familiar with is in the realm of risk prediction, risk assessment, risk prediction, risk identification. But I think as there's definitely a big intersection between more advanced data methods, predictive analytics, and improving diagnosis. I think that in a more robust program that would have a very big footprint in our program. I think it's inevitable, right?
Yeah, absolutely. Yeah, I do. I think it is inevitable. I think increasingly you're going to have these ML AI algorithms that are going to say, hey, here's your here's where you should go hunting from a diagnostic perspective, and we should really truly kind of understand that well. I think Patrick just jumped on and wanted to jump in from a comments perspective. I think Patrick, you'll be the last comment here.
Yeah, thank you. And I'm sorry I missed Dr. Brady's presentation because I had to run to another meeting during the lunch period. But I did do, in preparation for this meeting, I reviewed the slides and did a little mini survey of our Chief Quality Officer, Patient Safety Officer at my own healthcare system and the quality manager. And what I heard from them in terms of patient safety challenges and AHRQ's role, two key things. One we've already touched on, which is the move to telehealth and how do we ensure safe care by telehealth, and how do we measure safety in a telehealth context. And I think that fits with what we talked about a little bit earlier this morning. But the second point is just this huge continuing switch to ambulatory care. And our group, the Yale group, others have spent decades developing measures focused on inpatient care, where the denominator is inherently about patients who are admitted to the hospital. And yet, I don't even know what it means to be admitted to the hospital nowadays. When we have observation patients who stay 2 midnights in the hospital, who occupy a hospital bed, who were treated by hospital nurses, and yet somehow they're not inpatients. And then we have ambulatory surgery patients who routinely stay overnight. They're not inpatients. So we are just having, I think, a huge problem with really trying to figure out the data needs, the measurement needs with this switch to ambulatory care. And, of course, AHRQ has been a leader in terms of having the SASD program with the ambulatory surgery data sets, the emergency department data sets. And yet, those data sets are so much more limited compared with the inpatient data sets. They vary a lot across states. States have different licensing standards as far as what ambulatory surgery centers contribute to the state data programs. And so there are some real challenges in terms of figuring out safety. The events that patients have that we've traditionally tracked are now increasingly happening after patients go home. And how do we find those events? How do we attribute them back to the patient who was treated? So these are real challenges in terms of as the distinction between inpatient and outpatient care has become blurred, and yet the data sets are not blurred. The claims are not blurred. They're still in these distinct boxes. And so it has created, I think, real challenges from the measurement perspective, from the risk adjustment perspective. How do we get the information needed to understand the risk of different patients, and of course, the quality improvement and safety improvement challenges. So just encouraging AHRQ to sort of think more about those issues.
Outstanding. Very, very good. So really rich discussion. I hope, Jeff and Aaron, you all got something out of this. Outstanding. Sounds like you did. That's great. So with that, we will move on to public comment. There are 2 public comments. So we'll start with Shannon Davila from AHRQ. Please remember, for those doing public comment, that public comment is limited to 3 minutes. There will not be questions after the public comment. Let's start with Shannon Davila.
Good afternoon. My name is Shannon Davila. I'm the Associate Director of AHRQ and the ISMP PSO. I'm also the co-chair of the AQIPS National Safe Table Committee. Thank you to the Council for allowing me to speak today. I'm excited to be with you today to inform you of the PSO National Safe Table Program, where we bring together PSO workforce, healthcare professionals, patient representatives, researchers, and government officials to improve the delivery of patient care. So a little background, PSOs have been conducting safe tables for the past decade as a primary mode of raising awareness about concerning issues that keep many of us up at night. We conduct analysis and deliberations in a protected environment and distribute clinical solutions, protocols, and other practices that improve patient outcomes and the culture of safety. So the goals of our program are to, 1, create a national learning system to promote advances in patient safety on a national scale. Secondly, to align with the work of the PSOs, as well as implementing the National Action Plan to advance patient safety, as we heard Dr. Brady comment on a few moments ago. And then also to promote a national safe table forum that will address patient safety needs at a national scale. Now, our PSO program continues to grow and has already demonstrated proof of concept. We have multiple examples of national safe tables, including the National Pharmacy Safe Table, as well as some specialty clinician safe tables. There is a trend for PSO national safe tables to occur at national medical specialty meetings, including anesthesia, ER, pharmacy, etc., which really enhances the accessibility for interdisciplinary groups to have learning together. Now, what's truly exciting is to see that clinicians who have never been involved in quality improvement activities are leading many of these efforts and putting competitive issues aside by working together for the benefits of their patients. So just a sample of some of the PSO feedback that we have gained from some of these safe tables. We've seen the development of national practice guidelines. The Academic Medical Center PSO has created a great guideline for telehealth, for example. We've seen improved surgical and medical practice checklists. And for example, AHRQ and the ISMP PSO, my PSO, collaborated with the Maine Primary Care Association PSO to create a tool for clinicians to help assist in the treatment of intellectual and developmental delayed patients. We've also seen validated best practices. So what I really want the Council to take away today from my comments is that as a program, we are committed to efforts to improve patient safety and the quality of patient care delivery. As a learning system, we share patient safety learnings to achieve high reliability in healthcare. We are evidence-based and solution-focused, and we support providers to implement safety solutions to drive better healthcare outcomes. We measure and collect data, analysis, and best practices from PSOs to demonstrate improvements in outcomes. And we build our efforts upon models of successful PSO safe tables, as well as provider and PSO initiatives. We maintain a confidential and non-punitive learning environment, with all aspects of the operation of our safe tables are considered patient safety work product. And then finally, our best practices are distributed throughout a healthcare continuum through the PSO distribution system across our PSO community. So thank you again for the opportunity to make these comments, and thank you all to their dedication to improving patient safety.
Great, thank you, Shannon. Next up will be Paul Ebner from the Society to Improve Diagnosis, or medical diagnosis, maybe.
There we go. Can you hear me?
Yep.
Okay, great. Thank you very much for the opportunity. Again, my name is Paul Epner. I'm the co-founder and chief executive officer of the Society to Improve Diagnosis in Medicine, and also the chair of the Coalition to Improve Diagnosis, something Jeff referred to earlier. A quick congratulations to AHRQ on the recognition for its important work implied in the proposed budget increase. And also I'd like to express appreciation to NAC and AHRQ for what's clearly a prioritization of improving diagnosis as an important safety imperative. We know from our research that diagnostic error is the most common, most catastrophic, and most costly of all medical errors, and that has been reinforced in today's discussions. I'd like to make 3 quick comments. First, I encourage NAC as it deliberates on the many important topics brought before it to consider framing care delivery discussions as generally either part of a health problem investigation, which I call diagnosis, or part of its resolution, i.e. treatment, with equal opportunity for improvement. Whether it's an issue of telehealth or disparities or high value care or patient experience, treatment issues have relatively more limited and discrete choices than does diagnosis of symptoms, especially undifferentiated symptoms, with the inevitable uncertainty and variability in presentation and the lack of potentially very different kinds of input information. I believe this 2-domain approach will provide a useful distinction for generally improving quality. Second, relative to the telehealth comments, which I really appreciated, we think of telehealth as a unique setting on par with office-based care, clinics, ED, or inpatient settings, to name a few. We think of the complexity of telediagnosis as very different from telecare, where a known problem exists, and the opportunity for improved access and more timely encounters. While that's really a positive, it certainly needs to be balanced by research on what might be very unique failure modes associated with telediagnosis. In case you weren't aware, we are just wrapping up some PCORI-funded work to develop a research agenda for telediagnosis that involved getting inputs from nearly 50 people across individual and group listening sessions. It involved industry partners, professional societies, patient advocacy groups, and other experts in the field. Finally, with respect to patient engagement, I was encouraged by Patrick's and Sue's comments this morning. I would like to highlight that which is known to all of us, that the delivery of care is increasingly fragmented, and the only participant that has complete, even if it's imperfect, knowledge of the entire experience is the patient. They're the only ones who move from setting to setting to setting. We need to continue to focus on ways to strengthen their role, not just in many ways the current notion of engagement, but more along the lines of co-production of diagnostic and treatment plans in all that we do. Certainly, the recent adoption of a clinical note availability or open notes provides one new data source, one possible vehicle for increased engagement and co-production, and that is a new data source. If we could increase the read rates, et cetera, that we could try to find, as Sigal Bell has done, that in the corrections and the amendments to clinical notes is important information about the diagnostic process. I'll wrap up with an invitation to attend our virtual conference in the fall when reducing disparities, improving diagnosis is the theme. Conference chairs Peter Pronovost and Ron Wyatt have assembled an amazing list of speakers to include Tejal Gandhi, David Ansel, Chris Castle, Maya Dusenberry, Saeed Ibrahim, Urmi Malasarkar, and others addressing the issue of racism, genderism, ageism, and other attributes that lead to suboptimum outcomes. So with that, I'll turn it back to you, and thank you very much for the opportunity to address you.
Thank you, Paul. Appreciate your comments as well. With that, it is wrap up time. This is the time where I get to pick what we're gonna do. So what I decided to what I'd like the NAC members to think about just for a minute or two are takeaways from the overall day, right? So we talked about, we had the AHRQ updates, including the budget. We had robust discussion around telehealth. We had another robust discussion around patient safety. And so if you can think to formulate a way to pull it all together into a takeaway. What I'd like to do is I'm gonna take a few three. I'd like to get three folks kind of commenting on what the takeaway is for the day today. And while you're thinking about that, if there's anyone who wants to jump in on any suggestions for topics for future meetings, please let us know now, or just you can jump in, take yourself off mute, or shoot a note into the chat section while you're thinking about your takeaways. I know I sprung this on you, so I'm gonna have to at least give you a minute to think. All right, so I am a bit of an open forum. You can either kind of raise a hand, say you have a comment, or just jump in. Ram, I didn't see you, but go ahead. So takeaways, Ram, what do you have?
Again, it's a great meeting with the wonderful, wonderful topics. And a suggestion would be that we have been on this quality and safety journey for the last 20 years or more. So at some point, we need to really say, wait a minute, how far we are going forward with it, because this should become an automatic given in any organization. If you do something for 20 years, then that becomes like a normal part of doing business. So we don't really focus on it anymore. So with that in mind, I think I would like to see more of research being done in the operations, because one of the things we are trying to do on the equity as well as on cost containment is how can we make the healthcare operations easier for the patients and also less expensive. So I would like to see something on those lines in the future. Thank you again. Great meeting. Wonderful. The chair has done a phenomenal job, and great to be a part of that.
Awesome. Other comments that have come through. So that's great. So that, how do we really dig in on operations? Other comments in terms of future topics. I think Asaf will talk a little bit about kind of care at home, quality, technology, the payment, patient engagement, all of those components that wrapped into that. Melinda talked about really, actually, this is a discussion that I think AHRQ tries to do this, but Melinda really talks about what's the effect of AHRQ, like how has AHRQ moved the needle, and how do we? And let's have that would be a really interesting conversation in terms of one, looking backwards, but also looking forward, and saying, and really pulling that kind of pulling that thread through. Really, really interesting. So I saw Chris's comments as well, and additional resource investor initiated health service research. Okay, great. So and Patrick had a really great comment as well. Any other themes or takeaways that folks want to pull together now that you've had a minute or two to think?
Yeah, this is Asaf. I really hear really in the last few meetings an interest in this is building on Ram's comments and others, how while we're interested in the breakthrough innovations of the future in safety and quality and patient engagement, how we really think about systematizing and implementing the implementation science research that has been funded. And that really means both on an operational level, but really thinking about this field of follow through. I mean, AHRQ does a great job of funding breakthrough innovations. And it's no fault of AHRQ, but it's really hard. And who is funding the follow-through innovations that are part operations, part implementation science, part policy prioritization, and part sequencing. And I said this in my earlier comment, I love the safety report. The only request I would have, even though the implementation guide was fantastic, is the sequencing. Which should we do first? I mean, we don't have a clear answer, but we've got to start somewhere. And we have named actors in each of these problems. So what are the key steps and sequences and actors for follow-through innovations in all of these important fields?
Yeah, really good.
If I could, I have a real quick comment just about the meeting in general. I really appreciated getting the slides as we always do. I think having questions in advance that we should be thinking about was extremely helpful. It gave me a chance to really go out and get some feedback from a diverse group of individuals with whom I work. And I have to say, as much as I love hearing from people, our colleagues at AHRQ, getting the slides in advance and having them blow through them quickly enough that we could have more conversation during the meeting, I found really stimulating. I love hearing from other NAC members. And I think that the opportunity to have our experts with us from AHRQ, but really pump the questions to others that are on NAC was really, I think this is the best NAC meeting I've ever participated in. And that's saying a lot because I like all of them. So thank you.
Awesome. That's really great feedback, Chris. We will certainly take that back. And for what it's worth, I completely agree with you. So there you go.
This is Greg. If I could just jump on that too. I think that I really appreciate Chris's comments. And I think that, you know, it's been an interesting 2 years being on NAC because the funding issues have really gone up and down. And it seems like looking ahead that things are really positive for AHRQ. And I'm excited to see that because I think that means that AHRQ can address more emerging issues and address gaps that have been identified by the NAC. And with that being said, I think there's really an opportunity with 7 new NAC members coming on, that there is an opportunity for new ideas and that, you know, there needs to really be a very strong consideration for what members' experiences are, who they represent, and what they can bring to NAC, so that it continues to be a very well-rounded group that has perspectives from every aspect of healthcare, community, acute care, long-term care, with multiple types of technologies, multiple interests like families, caregivers, the providers. And I think by doing that, it'll increase the synergy and the communication, and the discussions will even be richer.
Yeah, agreed, Greg. There's one theme I want to pull through from the day. It shouldn't be a stretch because it's a core component of what AHRQ does, but I'm thinking about equity. And I'm thinking about equity in terms of, you know, the presentations that were done around the work that AHRQ is doing, as well as David coming in around the budget and, you know, and the focus there, and an ability to really, you know, kind of even double down on some of that work, especially with the administration's focus around equity. And then I roll that right into telehealth, and you think about, you know, we talked a little bit about, you know, digital divide. We talked a little bit about access from that perspective. We think about it from a rural perspective. You know, we think about it from a broadband perspective, from a device perspective, from a digital literacy, digital health literacy perspective. And then you pull it into safety, and how do you truly have a robust patient safety approach without factoring equity into that conversation. And so I think that appropriately so, one of the themes to pull through the day, I think, would be equity. There's one other comment I actually wanted to bring in into this part of the meeting as well, which is because I know it's in the comments, will be captured, but I just wanted to reemphasize this idea, and again from Gretchen, this idea that we pull in patient, resident, consumer input, interest, engagement in the work that we do. And you could pull the equity theme back in as well as we think about specific vulnerable populations. And again, we do this, but it's so critical. Yanling always holds us accountable to this as well, right? Making sure that we're getting that voice in everything that we do. We know that that's hard work, but it's so critical. And we really should continue to emphasize how important it is.
And Mondo, I just want to add that as you say, or as you saw, that we were recruiting new NAC members, we're always looking for folks in that category too. And so if folks have other ideas about patients or consumers you think would be really great for us to have on our NAC, please send them our way.
So with that, and not seeing any other comments or questions, I'd like to, as always, thank the AHRQ staff, including Jeff Brady and Arlene Behrman and Joel Cohen and David and Keith Cannell and Jamie, of course, always, Aaron, for your presentation. And first time I've got to see you present, the whole team that was able to pull this together, all the folks behind the scenes, getting all the technology, including my technology issues. Sorry, guys. But just thanks for everyone contributing to a really good meeting. I think what I'm seeing in my notes is that this will be Karen Brooks' last day today. Is that right?
Yeah. So Armando, it's not her last day, but it'll be her last time coordinating this meeting. I know many. Okay. I just wanted to take this time to say, thank you to Karen Brooks, who has been with AHRQ as a contractor supporting our NAC she actually predates me in supporting our NAC, which is pretty a long time. So anyway, just want to thank her for all of our hard work and over the years, and really for shepherding all of our, as you know, you all have worked with her to help kind of get your paperwork along and ethics to make can move that as quickly as possible. So we will miss her, and she will certainly have big shoes to fill, but we will have Susan Karen taking over that role, and we'll be introducing her to you. But thanks again, Karen, as you move on to your future endeavors.
Oh, well, thank you. It's been kind of went by so quickly, but looking back, when I started working with AHRQ, my son was 9 months old, and now he's going to be a senior in college. So I originally wanted to wait one more year to work to retire. I don't know if you call it retire, but after being cooped up for a year, I'm ready to step away from work and do some traveling with my husband. So anyway, but thank you all. It's been a fun ride. I appreciate it.
Awesome. Thank you, Karen, for all that you have done for us and really making this, and for certainly for me and helping us get these meetings together and just being organized. So in all your work, and enjoy your time and your travel.
No, thank you.
Awesome. I think the next meeting is in person. Right? Maybe not. We're still. I'm gonna just put it into the universe that we're gonna be meeting in person in November.
We should always plan.
It's November 17th. Is our next meeting, and my last meeting as chair. And I think that's it for our business. With that, I'd entertain a motion to adjourn.
So moved.
Anyone? Oh, and a second.
Second.
Awesome. It's been moved and seconded. Assuming there are no objections, we are adjourned. Thank you, everyone.
Thank you. Bye.
Thank you.
Thank you.